to understand the pandemic better. And those are some of the questions and learnings which we need to keep following. But to generate evidence, we need to have a data. And one of the challenges in this pandemic has been the absence of data for decision making. Either the data which was available with the government was not widely shared, which is as good as no data, or the sufficient data was not available or generated. So those have been challenges. And we know that in this pandemic, some of the better quality data, good data came from independent academic institutions, not in India. No such institution existed in India, but definitely outside India. Many institutions were collecting and sharing data in the public domain, which was far better than what was shared and provided by the government. But we should not be focusing only on this pandemic for the data. Data is important for the healthcare service delivery. So hopefully there would be some learning in this direction. Another highlight of this pandemic was a shortage of personal protective equipment in the beginning of pandemic, shortage of testing services in the beginning of pandemic. And these two indicate, these are simple, in my opinion, these were simple reflection of shortage of supplies in the healthcare sector, which have always been there. Shortage of testing services in general in healthcare services. So pandemic simply amplified the challenges which Indian healthcare system is facing. However, at the same time, there is a silver lining. The challenge of shortage of PPE and testing could be addressed over a period of time, which also indicate that if we focus on, or if there is a strong desire from the government to address the challenges of a short supply of medicines, diagnostic testing in general for health services, it can be done for a routine health services also. Another learning and discussion during the pandemic has been that related to something that is very popular and widely known in Thailand. They call triangle which can move mountains. And the triangle of which can move mountains is in the Thailand policy circle, health policy circle, is politicians or policymakers. That's one group on one end of the triangle. The technical experts on second aspect, and third is the community participation. And I believe that even in India, that approach probably for the first time has been followed, where policymakers, public health expertise, and communities have worked together to address a challenge. Now, of course, it is arguable, and some can say that it was a policymaker-led response, but we know when responses are dynamic, one group sometimes predominates, but it's very fluid, it keeps changing. But ideal approach and a perfect approach to solve the policy problems or bigger challenges such as routine healthcare challenges or pandemic challenges are all three working together in the right balance. There is no standard formula for that, but we should remember that even if public health expert would give advice, unless policymakers are willing to accept and implement, or communities adhere to that, or willing to accept those services, it will not work. So just a thought on that. Finally, another challenge which we realize in this pandemic is the private sector and pandemic response. And one of the revelation is that when there are challenges, it's only government health system which delivers healthcare services. We know that in the beginning of the pandemic, soon after the lockdown, most of the private sector facilities were closed or functioning minimally. Majority of pandemic response services, testing services, treatment services were being provided by the government health system. And even when private sector opened up slowly, the cost of healthcare services was gone really high. Like even cost of routine consultation service was increased by 20 to 50%. The testing services, cost of testing was extremely high and unaffordable to many people. So much so that Indian government or states had to put a price cap on both cost of testing services and cost of hospitalization services. What it reflects? It reflects, or it can be interpreted in 2-3 ways. One, while private sector is an integral part of Indian healthcare system, a stronger government healthcare system is required if we want healthier population. Second, this was the first time there was a clear acknowledgement and without protest from the private sector that private sector healthcare services are really expensive and unaffordable. There is an example where insurance regulatory authorities also did not reimburse the costs which were charged for a COVID-19 treatment, saying that these are excessive costs. So which reflect the excessive cost and exorbitant price in private sector. And third learning in this is that in absence of good regulation or effective regulation, private sector is going to be very expensive and unaffordable and result in inequity. So for the first time, Indian healthcare system effectively used the price regulation to make health services accessible. So there are many learnings for the from the private sector and pandemic response, and each one of those need to be discussed in detail. But the key in public health and key in policy making that we keep learning. So where are we now? So to answer this question, that we have seen a few things, we have derived few learning. We are still in mid of the pandemic. That there are graphs available widely. The epidemic curve in 1918, 1919 pandemic was very different. There was the first small wave, the second large wave, and then a third small wave. But there are many graphs emerging for this pandemic, and what we know that this pandemic of COVID-19 is not following any standard curve. We don't know which direction it will move. Every country has followed different pattern, and there is a need for a regular data collection, and epidemiologists keep looking at that, how to make sense of it. Second part is that we have seen a lot of progress in development and science and research and development. The vaccines, which in my opinion are undoubtedly a public health tool around the corner, will help in the world to come out of the pandemic, but of course delivery will be a challenge. What we have also learned during this pandemic, that it is the healthcare system we need, not the medical care system. And the reason or the rationale for my argument is that we have seen that some of the best healthcare, so-called best healthcare system in the world, United States or European system, did not succeed in controlling the pandemic, but a few others succeeded, because those healthcare systems are medical care systems. United States is one of the most medicalized healthcare system. There's no attention on primary healthcare, and that's why they struggle most. So medical care system failed, but wherever there was a healthcare system which was primary healthcare focused, the healthcare which comprised of curative plus public health services of preventive promotive succeeded. And the examples are Thailand, Vietnam, even South Korea, and many other systems. So healthcare system succeeded, medical care system failed. But as I have argued earlier, that no system is fully prepared for pandemic. The only difference is that if you have a well-functioning system, you can step up or ramp up your efforts quickly, but of course additional effort or surge capacity is required for all these aspects. I'm aware of the time, so I'll go a little faster, but I'm just trying to touch some key points. Learning emerged from all different countries, and Thailand, Vietnam, they are key learning. Stronger primary healthcare system, which is well funded by the government over a period of time. Attention on prevention, on preventive and promotive measures helps. These learnings will go on for a longer period. Of course, I have highlighted that how in success of any intervention in general, but public health intervention in specific, the community participation is key. We have seen from Dharavi that when in government tried to implement the standard approach of contact tracing, people simply did not offer or provide the information which government needed. So they had to change their strategy and engage with the community and provide them some water supply and some improved toilets and set up facility there with the community engagement. And that's how Dharavi, which could have become a real hotspot, actually could control pandemic really well. And if there is one early success story in pandemic, it's Dharavi, though in pandemics, we should not be going for success story till pandemic is actually over. Quickly coming to the last part, and I have already reflected on all these aspects. I also want to keep some time for if there are one or two questions. So I'll quickly go through these ones and hope, and then we will take questions maybe. So some learnings, and these are the bullet points, and I could have easily spoken about these in detail. So the first learning is that well-functioning primary healthcare services. And a stronger public health services are essential to keep society healthy. The smaller facilities can play a bigger role in providing health services. We have seen from the Italy that people who had initially started coming to large hospitals, and that's how this entire infection spread. And if you're a primary healthcare facility, it works multiple ways. We have learned from the pandemic that health is about broad range of services provided, not about curative medicines. We know that non-pharmacological interventions are equally important and effective, and we need to scale up those services. Laboratory and diagnostic services are integral part of healthcare service delivery. With better functioning, government health systems are more effective in early response to pandemic. Private care sector can supplement, but cannot be the core. Health services entail teamwork and between health and non-health contributors. So we have seen within hospitals also doctors, nurses to the ward boy, everyone need to function properly. But if you look at the broader level, the curative service, but also contact tracing and the community health workers who are going to outreach facility are equally important. And the frontline workers who are not one place, who are everywhere, like who are dealing with the sick patient in the hospital to the accredited social health worker who is going to house collecting data and putting herself at risk. So they are heart of the health services. Private sector role I have already highlighted, and health and economy are interlinked. Rather, this point is very important that governments often do not invest enough on health. And now, once again, it has been highlighted that if you do not invest on health, the impact on economy would be far worse and unaffordable. So, what is wise to invest on health and by the government? Now, second last slide, and here I would go back to why I talked about UHC. So our response to pandemic and our approach to UHC are similar. UHC is about accessibility, availability, affordability, and quality, which means services should be accessible, available, affordable, and quality for all. The pandemic response is also same. Pandemic services should be accessible to all, like treatment, testing, other services required. They should be available, affordable, and quality. So if we have a mechanism for quality, for a mechanism for universal health coverage, which means services are accessible, available, affordable, and quality, our response to the pandemic would be far smoother. And we can tackle pandemics also if countries work toward advancing universal health coverage. I have highlighted some of the points, and this is the final slide. It's not all bad. India has done a really good job so far. There is a reduction in mortality, and of course, there were challenges, but there are some learnings also. One of the learning, or some of these learnings, we should use for strengthening public health in India. And one of the first learning, I would say that in the last 10 months of pandemic, 11th March onward, pandemic was declared, health has received wider public and political attention. It's our responsibility, combined responsibility, to build on that. The public health is being discussed at all levels, received unprecedented attention. We need to build on that. The importance of primary health care has been understood. So we need to build upon all these aspects. Angus Deaton, the 2013 Nobel laureate, had studied the various pandemics and of 19th century or 20th century, cholera pandemic and Spanish flu. And he made an argument that when European countries faced those cholera pandemic and Spanish flu, they immediately derived the lessons from those pandemics. They realized that they are real threats for the society and to their economic development. So they started investing on health. But probably in this part of the world, Asian part of the world, we have not derived enough learnings from the past diseases and their challenge on economic growth. So probably, hopefully, this pandemic would give some learning and countries would start investing in health. And that's where the role of public health community is, to bring all the challenges to the forefront and have a dialogue with policymakers. Thank you very much.
Thank you, Dr. Laria, for a wonderful talk highlighting all the important aspects, how to tackle pandemic and what is the importance of public health intervention vis-a-vis the curative medicine, the role of government system, as well as the vis-a-vis the role of the private sector. And I think a lot needs to be reinforced and talked about it. And since it's a virtual seminar. So I'll be opening it up, and I'll be going to my co-chairperson first, and I'll request Dr. Rasania to kindly say a few words, and if he has some questions in his mind from the expert, then he is welcome to ask. Over to Dr. Rasania, sir.
Thank you, Dr. Harivansh. Very good morning to everyone, to all. Dr. Chandrakant Hariya, thank you. Wonderful, wonderful, wonderful presentation. As usual, I must say as usual, because I have heard a lot, and many times I have heard in many other places and I really feel proud that you are at a position from my institution, Lady Head Medical College. So you have a wonderful association with our institution, our department. In fact, the presentation in this seminar, in this conference, your presentation related to pandemic, public health, and lesson for health system strengthening. In fact, you initially, whatever you said, that interlinking of pandemic with public health, really it is a wonderful thing. What I personally feel regarding this pandemic is that you see, we were not having much of the information about this pandemic, and most of the information, most of the experience, whatever were based, it was based on assumption. That's why daily, every time there was a different guidelines were issued. And moreover, we are not having any genuine data initially. Whatever data was available, it was uh, a big question mark on that. So somewhere, what I personally feel that initially it was not in the right direction, pandemic control activities, but somehow later with many of the public health in. And yes, one more thing, one important thing was that somewhere the public health was neglected in this. I don't know whether they were might be they were not able to take the lead in pandemic control. So, Dr. Chandrakant, in fact, if you can throw some light on that, why somewhere the public health was either neglected or were not able to take lead? You can, if you can give some comment on that.
Yeah, thanks, Dr. Sania, for kind words. I guess that's a dialogue which we need to continue in the future. However, I would say one of the key thing is that where is the baseline? Where are we starting? The public health in India does not get enough attention in general also, and that's a real unfortunate part. So, in this pandemic, I personally feel that like some of the argument which have been made that it's only politicians led or other aspect are true at different point of time, but it's a dynamic process in the pandemic response, and where things keep changing. Sometimes public health gets more attention, sometimes politicians get more attention, but it boils down to the starting point. When public health is weak and it never received attention, we probably are 10 months down the lane in little better position where public health, importance of public health is understood. It is getting far more attention than earlier. And probably there are areas where public health association, which have played a really wonderful role till now, already highlighted, but now beyond highlighting, building on what we are saying and showing them that this is what can be done. For example, the issue of data, which is really weak, but can we do something with the data or spending once pandemic is over? So I would not try to answer this question fully. The summary answer is that the baseline was really low. 10 months down the lane, situation had changed. Public health is getting more visibility, and we can probably benefit or use this opportunity to bring attention on this. But this will be a slow process. In my opinion, it will take a few more months.
But see, when I joined Central Health Services at the time during plague outbreak, public health was given importance. Gastroenteritis outbreak, public health was given importance. Even polio, public health was given importance. But this pandemic, not much. See, even on various platforms, national level or various level, public health was neglected. I think somewhere this was the most weak part, I personally feel. So what are your comments on that?
Yeah, so that's what I'm saying, that immediate response in the pandemic is very different. But probably to me the key question is that how best we can use this pandemic and learnings from the pandemic to transform public health in India. Talk to politicians that this was whatever has been done, and how, no matter who took the initiative, whether politicians or some clinical medicine, but everything which has resulted in success or effective response to pandemic is a public health response. And if we can use those learnings to make a case for extending public health in India, I think that will be the success. In the immediate pandemic period, or the ongoing pandemic, there would be very little which could be changed, and it would be unfair also to expect that it could be changed, because everything is being done in a much different way, where questions need to be answered immediately, and whosoever is there trying their best, so it's a overall challenge of Indian healthcare system. I would say that I don't expect immediate change in the pandemic period, but I hope that it will bring change in public health scenario in India once pandemic is over, because that time we need to sit together with the policymakers and work with them. So that's summary answer.
Okay. Okay. Thank you.
Okay. Thank you, Dr. Asania. And now I'll be going to Professor Sanjay. Professor Sanjay is also President of Public Health Association of India. So now it is over to Dr. Sanjay, and if you'd like to comment or ask some question from the learned speaker, you are welcome.
Thank you, sir. And thank you, Dr. Chopra and Dr. Asania, both the chairs. It's really, first of all, I would like to congratulate Dr. Chandrakant for selecting a very relevant topic and also speaking nicely. Really, I always enjoy his listening to him. So thank you, Dr. Chandrakant, for a nice talk. And you covered almost all aspects of this pandemic, from test, treat, track to migrant crisis. But this is regarding migrant crisis. See, this happened only in India, not even in the poorest. Although you said that this type of pandemic affect more poor and marginalized community, but this type happened only in India, not even in Sub-Saharan Africa, where they are really more poor, and if you see disadvantages. So this is mainly because of our containment strategy, right? Either premature containment strategy, whatever. But this happened due to this is my opinion. I want your opinion also on this test, track, and treat strategy. See, there are various phases of pandemic. Beginning, I can agree with the policy makers about this strategy to test, isolate, track, and treat, right? Whatever evidence we generated in last 10 months, we found that even during our pandemic, the first sero survey conducted by ICMR in the month of May, so around 30th April was baseline, and that time total number of cases were around 35,000 only in this country, and they found 0.73% the prevalence, sero prevalence in this country. And usually sero prevalence underestimate the overall burden because of the various reasons, right? So this is the bare minimum number, 0.73. If you convert into the number, it's more than 1 crore. That means we detected even that time hardly less than 0.5% of the total estimated cases. But we are spending almost more than 100 crore rupees per day on this testing. So what is your opinion on this current initial phase? Okay, we can accept this type of strategy, but what is your opinion on current ongoing practice, same practice even after 10 months we are doing?
Thanks, Dr. Rai, and it's always learning. So I would say that these are my personal opinion, because my organization always have said these strategy, test, trace, treat. As far as the data, we can fight pandemic based upon evidence and information available. And evidence or information can come through some approaches, and testing is one of the key strategies. Now, how much testing should be done, whether the testing should be focused, that is definitely a strategy and debatable issue. And India has kept saying that it is following the testing with purpose, that what is the purpose? Initial stage different purpose, and now later stage different purpose. what is the right balance of testing? There is no answer. So these are the local strategies which need to be followed in a high focus setting, such as Delhi, where the number of cases are being done. So testing is not only number of cases are high. The purpose of testing is not only the public health purpose. For example, an individual who feels that he need to get tested for himself, then if it's individual initiative testing, that's a curative intervention, because I want to take care of my health and I want to be tested myself. So that is a different purpose. But public health testing is that you want to trace the level of infection in the community. So what the testing which we see in the pandemic is combination of two: curative approach or individual specific approach and public health approach. And that's why when two are combined together, the number of tests are very high. I guess we can have a detailed discussion on that, and I have my own opinion on points, including on zero survey. The summary point is that when we are in the pandemic, if we say, I don't know the number, but as you say, 100 crore rupee per day are being spent, which is still very, will come down to less than 1 rupee per person in this country. 138 crore people are there, then you have 100 crore per day. So less than 1 rupee is being spent on testing. India need to spend much more on healthcare services. But of course, we can argue that the money which is being spent on the testing could be used somewhere else. But these are the points which need to be further nuanced. We can argue that Delhi probably should do more testing, but a remote town or village should not do. But we really don't know whether there is sufficient testing is being done. Or we don't know for the future that what will be the implication if we start reducing the testing. Can it result in excessive spread of infection, which would have a future excessive cost on the treatment or the spread of the virus? So there are many unknowns. These are locally adopted strategies. Broad principles are being followed. And I think what is being done, 1 million tests for a country like India, is perfectly all right. But I'm not going into specific this thing. I have written about zero survey, I have written about testing this thing, and there are many nuanced part of this thing. Quickly touching upon zero survey part, for example, we know that in 1 crore out of 138 crore people had come out from the first zero survey. But 3 months later, we had a 7% of the population, which is around another 10 crore of 138 crore population. What we know that if 10% are 7% or 10% have developed infection, 90% are still susceptible. We have many unknown, such as that what is the threshold of herd protection. We don't know that in the world, no disease could be prevented or stopped only by the herd protection without a vaccine being available. We don't know how.
Sorry to interrupt, sir.
Yeah.
As we are running short of time, we would love to conclude now, sir.
Sure. So those are the points, and that's why I was trying to kind of.
Yes, sir.
Okay. Just a minute. Let me give my concluding remark, and then probably we can conclude. Dr. Laria?
Yes, I'm here.
Yeah. I just want to say two positive we can take from your talk as well as from this pandemic. Like when it started, it was a national level directives and the guidelines were as far as the control of the pandemic was concerned, and gradually it came down to district level. Now, if we can take up this district level planning and implementation in the routine health services also, I think that will become a game changer as far as the public health is concerned. That is one point. The number 2 point is, which we have not talked about, that is the prevention paradox. What is the role of prevention paradox as far as the public health interventions are concerned? That needs to be explored further. And third and the last most important point is that, yes, we have been able to regulate private sector, but we have not been able to regulate one important component of our democracy, that is media. The media is highly unregulated. Rather, we should have used media in a positive manner where they must be forced to show the best public health interventions like wearing of mask, maintaining of physical distance, and hand sanitation and hand washing. Why it can't be made mandatory on every channel, on every program, whenever they start and finish? It should be made mandatory so that ultimately it is people who are going to control the pandemic. No government can control the pandemic, as you likely said. So I think the take home message is this, that people's participation, the community participation is key for the control of pandemic. And you have highlighted this fact very well. So thank you so very much for your enlightening talk. And I hope everyone must have enjoyed it. Thank you so much. And I give the mic back to the organizers.
Thank you very much, everyone.
With this, we conclude our first session. I would like to thank our speaker and all our chairpersons for having such a wonderful presentation and discussion. Now we move on to our second session. We have Dr. Shankar Prinja as a speaker with us for the second session. Sir is Additional Professor of Health Economics at PGIMH School of Public Health, Chandigarh. Sir will be speaking on affordable healthcare in India, current situations, way forward. For this session, we have Dr. Jugal Kishore sir as a chairperson. Sir is Director, Professor and Head Community Medicine at BMMC, Delhi. We have Dr. N.K. Saini also with us. Sir is ex-Director, Professor, Community Medicine, LHMC, New Delhi. Dr. Arun Agarwal, Sir is Professor, School of Public Health, PGIMR. He will be joining us shortly. Now I invite Dr. Jugal Kishore sir to introduce our speaker. Sir, please.
Thank you, Dr. Sweta. Thank you, the organizers. And last minute, I have been pitching. I still don't know what is the session. But anyway, I know Dr. Shankar Prinja. Whatever he's going to speak is going to be worth listening to all our viewers and also students. He's a renowned name. Everybody knows he's additional professor in health economics. Very like it is a very emerging branch, and still looking forward more health expert in this field. His main research interests involve the economic evaluation of health care interventions and programs, which is again a very important aspect. We just plan and then implement, and we don't know what is the economic evaluation of it. So he is expert in all these things, analyzing impact of the health financing policies in the context of the universal health coverage. He's a member of several high-level technical experts group, and is also part of the subgroup of ministers, prime ministers, economic advisory council uh, on the investment in human resource and infrastructure. So he's highly placed and have the vast experience. He has experience in the costing and particularly the healthcare services, and also involved in the development of the PGI Chandigarh School of Public Health, particularly establishing the resource center, regional resource center for the India's School of Public Health. Has established this health technology assessment board, and that's a very very important one. That how you have to assess, and the costing is part of it, and economic evaluation is always a part of it. You should have the innovation and all the technology, but at the same time we should know what is the the economic aspect of it. And his active involvement, I think, is well recognized, and everywhere wherever we are talking of health economics, one name comes, that is the Shankar Prinja. And he has authored many papers nationally, internationally, and he's an academic editor of the PLOS one, that is again a very prestigious journal. So I invite him without wasting time to deliver his talk. Thank you, Prinja.
Thank you very much, sir. Thank you very much for your very kind words. I hope I'm able to. I hope I'm able to give some meaningful message. So coming after Dr. Chandrakant, I see that there are a lot of commonalities between what Dr. Chandrakant has already mentioned and his vast experience that he's put into his new book that has recently been released. So I see that there are, as I was hearing him speak, I saw that there is going to be a bit of a repetition between what he said and what I'm going to say as well. But I think that the way he projected all those lessons were quite largely drawn from the pandemic experience. And I'll try as much as possible to base the arguments that I'm going to make on based on the general healthcare scenario. So I was asked to speak on affordable healthcare, current status and way forward. But when I started preparing this talk, I realized that it was too much for me to cover in half an hour or so. And so I specifically thought that let me not go into the current status, which will automatically come as part of the whatever I suggest as a way forward. So I'm going to spend less time on the current status, but I'm going to say more about way forward and what should be the prescription for affordable healthcare. But as I give that prescription, I would obviously reflect upon the arguments that I'm giving based on the data that exists from the current status. The second thing is that I thought that rather than giving an outline in the beginning and keep letting people wait till the end for the conclusion, I thought that let me say what I want to conclude in the beginning itself, so that there is there's no surprises left for the end. And I'll begin with the conclusion and the recommendations that I'm trying to make, and then I'll pick up each one of these and then go into details of each one of these. So my key recommendations for affordable healthcare are A, we need greater public investment. That is beyond doubt. And I think there's a large consensus on this issue that we need more resources for healthcare. And this is something that Dr. Chandrakant has also emphasized very adequately. The second point, again, which he's also made as well in his talk, is that we need a very strong, strengthened public sector, and we need comprehensive primary healthcare. So that's the second recommendation that I'm going to make. The third recommendation that I'm going to make is in the context of the other component of the Ayushman Bharat, which is the PMJY scheme. And so having set up this scheme, what we need now is better governance and better incentives for the private sector, and regulation of the two Ps, the private sector and the prices. Again, something that came up in the last talk as well. And finally, I will move on to making two last conclusions, that we need ultimately to move towards a healthcare system that is not focused on volumes, but is focused on value. And finally, that we need to prepare ourselves better for the future pandemics. So the first conclusion that I said was that we need greater public investment. Now the key question then comes in, how much is it? How much is adequate? And to answer this question, that how much is adequate, we can perhaps take three ways of answering this question, that how much money do we need? So one of the ways could be that we simply compare to countries outside of India and say that, okay, how much are those countries spending who have some reasonable degrees of universal coverage? The second could be that we try and relate the outcomes of healthcare spending and say, okay, if we are able to spend at least this much, then we will be having some good, decent level of outcomes. Or the third option for us to assess that how much do we need is a kind of a need-based assessment. That means we assess that how much are our healthcare needs, and then say that how much is the cost that is required in order to meet those healthcare needs. So I'll take these three approaches and then say how much is what is required. Just to say that what are the levels of global spending, and these are per capita US dollars spent in different countries on healthcare. And we see that India comes up in a shade of light green, which is among the lowest, one of the lowest spenders at the aggregate level, at the per capita level. But you can always argue that, these are figures that are at the per capita level. So obviously the countries that are richer, they have more capacity to spend on healthcare as well. And so we can always expect them to spend more per capita on healthcare as well. So then what it means is that perhaps a better way to compare the healthcare spendings is that we look at the healthcare spending as a proportion of the GDP, because this is the level of spending on healthcare that you are doing, which is relative to your ability to pay, because the per capita GDP is a reflection of the wealth of the country. And this is an indication of how much is the ability to spend on healthcare. And if we look at the spending of different types of country, the different groups of countries, the low income, the low middle income, upper middle income and the high income countries. And if we see what proportion of their GDP they spend on healthcare, it's about nearly 6 to 8%. That's the kind of ballpark, with the average close to about 6.6%. And within that, the more important point that we need to notice that the proportion that is spent out of pocket is actually on an average about 32%. That means 1/3 of that only at the global level is what is spent out of pocket. And even in the poorest of the poor countries, this is about 41% of the total spend. Now, if we compare it against our own country estimates, we spend close to anywhere in the range of about 4% of the GDP on healthcare. But more importantly, we spend nearly about 68% as out of pocket. That means even if we compare ourselves to the poorest countries of the world, we are relatively one of the most privately financed and one of the most privately provided healthcare systems in the world. So which means that certainly we need to, up our healthcare spending. So the next question is, does government spending really matter? Is government spending really worth looking at the outcomes that we want to achieve? So let's first look at the right side graph, which is showing the levels of catastrophic healthcare spending, which is on the y-axis. And on the x-axis, we have the level of government health spending as a proportion of the overall health spending. And what we find is that the more the government starts to invest on healthcare as a proportion of the total health spending, the lesser is the level of financial hardship that people have to face. So which means, again, the more the government spends, the better it is in terms of the outcomes of the universal health coverage, the indicator for which is catastrophic spending. The other way to look at it is in terms of the equity of spending. And one of the indicators of equity is a Gini index. And if you have a value that is on the negative side, it means you are having more equitable outcomes. If you have something on the positive side, it means that you are inequitable. Again, the more you spend, the more the government spends on healthcare, the more equitable are the outcomes. That means you score better on equity terms. You score better in terms of financial risk protection if you spend more, if the government spends more on healthcare. And while this is an evidence that is more global, if we look at the evidence that comes from within our own country also, and this is a relationship between the spending at the level of the states and how much is the equity in terms of utilization of healthcare services. And this is reflected in terms of this indicator, which is concentration index. Again, it has the same message. Higher is the per capita spending, you see the negative correlation. So higher is the spending, the concentration index goes towards negative sign, which means that you have more equitable outcomes. A negative concentration index means more equitable outcomes, more pro-poor healthcare utilization. And coming to the last way in which we could analyze that, how much do we need to spend? And that's a more need-based prescription. And this is based on an analysis that we did quite some time back when the HLEG was established. And it was to estimate that if the government needs to invest for universal health coverage, then given the needs of the healthcare, how much does it need to invest on healthcare? And as a proportion of GDP at the national level, it came to close to about nearly 5% of GDP. So this is the ballpark where we want to achieve, where we want to reach. We are currently spending about, as the government spent is close to about 1.3 to 1.4% of GDP. The government documents or the policy documents aim to aspire at levels of about 2.5% of GDP, whereas the need is actually even double of what we are even aspiring for. So which means we have a long way to go. The second prescription for affordable healthcare is without doubt a strengthened public sector. And I make this argument of strengthening the public sector for affordable healthcare based on three arguments. The first is I would try and reflect upon what has been the achievement of NHM, one of the flagship schemes of the government since 2005, and where we saw at least some reasonable degree of spending that the government was able to do. The second, I'll try and make an argument based on public versus private, which has a greater potential to reduce the out-of-pocket expenditure. And the final argument I'll try to make on efficiency grounds. So if we just try and look at how have the outcomes in terms of the coverage indicators, how have they changed between 10 years apart between 2005 and 15? If we look at the NFHS data and if we adjust for all the other demand side confounders that could possibly affect the coverage of utilization, then we see that the coverage of all the services which the NHM focused on, it registered an increase in the utilization. Similar is the case with child health indicators. We had significant improvements in some of the key child health indicators. And we had a reduction in the level of health inequalities. And this health inequalities is being reflected in terms of what has been the difference between the poorest and the richest. What is this gradient? And we see that this gradient is actually falling in almost all the states. So in all the categories of the way you look at inequalities, whether it is EAG versus non-EAG, urban versus rural, caste-wise or wealth-based, in all these terms, it is not that the overall level of improvement happened and it did not happen in different subgroups of the population. It happened, the improvements happened in all subgroups of the population. And the same is the case with some of the other indicators. Now, if we look at out-of-pocket expenditures, now we compare the levels of cost or the expenditure incurred for a hospitalization among an under 5 child and for an institutional delivery. And if we compare the public and the private sector, during 10 years time period between 2004 and 14, after adjustment for the inflation, we see that there is a reduction in the expenditures that took place in the public sector facilities. Whereas on the contrary, if we look at the counterfactual, which is the private sector, there is an increase in the levels of expenditure during this period. If we look at the institutional delivery, adjusting for inflation, the values remain the same. But if we look at the counterfactual, there has been a significant increase in the levels of out-of-pocket expenditure. So the key message is that the NHM has been able to bring about a reduction in out-of-pocket expenditures for the services where it targeted to reduce the out-of-pocket expenditure. Or in other words, where the public sector invested enough, we could see that there is an impact on the out-of-pocket expenditure that people had to incur. And this translates into reductions in catastrophic health expenditures for both these two categories of indicators, both under 5 child hospitalization and institutional deliveries as well. And finally, if we look at the outcomes in terms of the final health outcomes, then we see that the rate at which the IMR was declining prior to the onset of NHM, there was close to about nearly 6 points reduction per year. Annual reduction was about 1.6 times per year. And there was an accelerated increase of about nearly 0.6 points per year in the infant mortality rate. So this is the amount by which the reduction in infant mortality rate can be attributable to the program, which was the National Health Mission. So certainly there is an improvement in the health outcomes also that we can see. So there's improvement in the coverage of service utilization. There is a reduction in the out-of-pocket expenditures that people were incurring, and there is an improvement in healthcare outcomes. So overall, and there was an improvement in the equity as well. So overall, we see that there is this public program led to an improvement in the outcomes from a UHC perspective. But we also know that this change in the IMR was not uniform across all states. So we actually ran an analysis to see that are there differences across states that can explain that what could be the factors that led to a more dramatic reduction in IMR in certain states and a relatively less reduction in IMR or no change in IMR in some of the states. And the factors that I've highlighted in red are the ones that were significantly related to reductions in the infant mortality. So obviously, female literacy and improved sanitation are two social determinants that we found were significantly related to improvements in infant mortality. And besides that, we found that the per capita health expenditure, the more you spend through per capita on health through the public systems, and this is the state treasury route, the lesser is the infant mortality rate. So so there is a clear-cut relationship. More you spend through public systems on healthcare, the lesser is the level of infant mortality rate. On the contrary, we had a finding which intuitively could give you a very wrong signal. That means the per capita spent through NHM, that means the NHM allocations, if we look at that, had a positive correlation with the infant mortality rate, positive association with infant mortality rate. Now, this may look like that, this may give a relatively wrong message if you look at it as without going into the way the allocations for NHM were made. So it may give you a wrong message to say that, you know, the more you spend through NHM, the more is the infant mortality rate. But that's not the correct interpretation of this. The correct interpretation is that the NHM allocations were actually meant to do some degree of cross-subsidization between the EAG and the non-EAG states. So there was an equity principle in the allocations for the National Health Mission that were introduced. The EAG states received 33% higher allocation to begin with. That means the state with higher burden received higher allocation. So in a way, this positive sign for the coefficient of the association between the health spending under NHM and the infant mortality actually says that your allocations through NHM, you were able to better target them to states which were having higher infant mortality rate. That means the vertical equity that you were able to achieve through NHM, or you were able to sort of bridge the levels of inequalities in healthcare financing between the poor states and the rich states. So from that point of view, NHM actually led to improvements in equity of healthcare spending as well. Now, this is a very interesting slide. It tries to show the mean levels of out-of-pocket expenditure per hospitalization. And this is using the data from the most recent round of the NSS. And it tries to classify the hospitalization into 4 categories based on either it is in the public or the private sector, and whether the hospitalization was for an individual who had no insurance or there was a publicly financed insurance that the individual had. And the interesting point is that if you look at the mean levels of expenditure in a public sector without even an insurance, was actually less than the mean level of expenditure in a private sector facility, even with the presence of a publicly financed insurance. That means what is more important to reduce the out-of-pocket expenditure is not as the health insurance is not as important or as significant to reduce expenditure. Health insurance does reduce expenditure. You see, in the private sector, the expenditure came down from about 22,000 to about 17,000. But even without an insurance, in the public sector, people are spending about, on an average, about 5,000 rupees. So which means the who provides the service, public versus private, is a more stronger predominant factor that affects the out-of-pocket expenditure than even the presence or absence of an insurance. So that again reinforces the message that we need to actually invest more on public sector provisioning if our overall objective is to reduce the level of expenditure. And the final point that I wanted to make is about efficiency. And this is the output of an analysis that we recently did for looking at the cost effectiveness of population-based screening for diabetes and hypertension. Now, what we show here in this slide, on the y-axis is the levels of cost effectiveness ratio values. So the values shown on the y-axis scale are incremental cost per QALY gained. And on the x-axis, we have different frequencies at which you could possibly screen the population for both diabetes and hypertension. So what we find is that whatever might be the frequency with which you screen the population for diabetes and hypertension, screening of diabetes and hypertension, given the current levels of healthcare utilization and the mix of utilization between the public and the private sector, it is not cost effective actually. So the levels of cost effectiveness ratios are above the line of threshold that we have set for considering any intervention to be cost effective. So all the values of cost effectiveness ratios are above the threshold, which means cost effectiveness of population based screening for diabetes and hypertension, the way it is, if the utilization of care once the patient is diagnosed continues the way it is currently being provided, the screening program that the government has introduced as part of the NPCDCS program is not cost effective. However, if you actually increase the utilization of those who are diagnosed, screened positive with diabetes and hypertension and put them on treatment at the health and wellness center, then your program becomes cost effective. So again, we show the same levels, same slide. I'm showing you different levels of different frequencies of screening, and at the current level of utilization, you don't find that the screening is cost effective. All levels of cost effectiveness ratios are higher than the level of threshold. But if you start increasing the level of utilization, the share of utilization of treatment for diabetes and hypertension at health and wellness center level, the more you increase, the more all scenarios start to become cost effective. So all those scenarios that are shown in yellow, highlighted in yellow, are actually cost effective. That means if you're able to put at least 10% of those who are diagnosed with screened positive for diabetes and hypertension on treatment at health and wellness center level, then your screening every 20 years and every 15 years becomes cost effective. The moment you increase it to 20%, even screening every 10 years becomes cost effective. And if you're able to put at least half of those who are screened positive with diabetes and hypertension on treatment at health and wellness center level, then even an annual screening becomes cost effective. So what it means is that you actually need to integrate your primary health, you need to augment the capacity of your public sector provisioning of primary health care, comprehensive primary health care through health and wellness center. And if that is done, only then your screening program becomes cost effective. So that's an important message in general for strengthening of primary healthcare as well, that adequate investment on primary healthcare makes your health systems efficient. The third conclusion that I had was around PMJY. And the key message that for PMJY is that you need better governance and better analytics. And as part of the overall implementation of PMJY, you need to regulate the private sector and incentivize the public sector. So why do I say so? I say so because in general, if you think that you'll have an insurance and insurance will lead to better outcomes, it may not necessarily be the case. So we did a systematic review, which was published in 2017. And it was a systematic review of impact evaluations of all publicly financed insurance schemes in India. And this is pre-PMJY. So this does not include PMJY, but it includes all state-specific schemes and RSBY that were prior to PMJY. So they show that all schemes, all these health insurance schemes lead to an increase in utilization. However, this increase in utilization is not necessarily among the ones who are the really socio-economically backward or the poorest households. This increase in utilization is more in districts that have good development indicators. It is more in districts where you have more number of empaneled hospitals, and it is significantly more positive association with private sector empanelment of the hospitals. So which means that there could potentially be even a supplier-induced demand that may be going on and not necessarily only a removal of financial barriers to access. But interestingly, these health insurance schemes did not necessarily directly result in a reduction in out-of-pocket expenditure. And out-of-pocket expenditures and catastrophic expenditures did not reduce in more than 3/4 of the total studies that were evaluated. Now that's an important point, which is the key to my conclusion And this is something that comes even in the evidence that comes after the systematic review was published. So even after that, in 2018 and 19, the papers that were published, they showed, besides just the studies that came from Karnataka, almost all other studies were unanimous to say that the findings are that the insurance schemes do not result in reduction in out-of-pocket expenditure. However, the new PMJY scheme, some people could argue that the original schemes, the earlier schemes had a very small benefit package. They covered only 30,000 hospitalization expenditure for a family of 5, which was the case in RSBY. But the new PMJY scheme has a much bigger benefit package. It has a coverage of 5 lakh rupees. So we evaluated that if you're able to increase the benefit package, and if you're able to increase it to about, let's say, 3 lakh rupees, then it does have a potential. So it has a potential to reduce the out-of-pocket expenditure by almost 85%. And it has a potential to reduce the level of impoverishment by nearly 93%. So it is not to say that in principle, the design of the scheme is not likely to result in benefits. The design of the scheme, even if it had a benefit package of 3 lakh rupees, it could result in a reduction in out-of-pocket expenditure of as high as 85%. And reduce the impoverishment levels by nearly 93%. And also to say that the SECC scheme, SECC, the socioeconomic caste census that is used to identify the poor, is a very good means test to target the poor. Unlike the BPL card that used to be the criteria for enrollment under the RSBY, this socioeconomic caste census has a better sensitivity and specificity to identify the poor. However, there still needs more improvement in accurately identifying the ones who are vulnerable. The other important thing that we need to have as part of the governance of PMJY is better pricing of the packages. And this is again coming back to the point that Dr. Chandrakant was also making about his when he mentioned about pricing, that we need better data for pricing, and there is now an attempt towards improving the quality of data for cost of healthcare services that can inform the setting of the package rates. And there's been a revision last year for the health benefit packages under the PMJY, which was based on the cost data. So the final comment is that we need, the key issue for PMJY for providing affordable healthcare is governance. And there are key issues with regard to design and implementation. We need better ease of operability. We need better awareness among the poorest. We need monitoring the care that is being provided by the private sector for its appropriateness, quality, and to ensure that there is no balance billing to the poor, to the people who are coming for the treatment. We need to create systems for incentivizing the public sector. So maybe there are certain services that are reserved for the public sector, or there is some degree of gatekeeping function that the public sector provides. And finally, as I said, that we need to price the health benefit packages more appropriately so that private sector does not charge to the patient. The fourth comment is that the prescription that I wanted to make for our affordable healthcare is that we need to have systems that are driven by value. We need to have value-based health systems and value-based healthcare services, and ultimately value-based prices of each of these services. Then only our healthcare will become affordable. So overall, our health system tries to achieve certain value. It wants to improve the health. It wants to provide quality services. It wants to achieve financial risk protection. And ultimately, all of that leads to certain degree of well-being, and it may create certain other valued outcomes. So for example, it may result in better educational outcomes, or it may have certain negative value also. Some side effects of medications may come in, or some side effects of over medication may come in. Those are kind of subtractions from the well-being. So overall, the health system tries to add value. And similarly, from a hospital's perspective also, if we look at it from a management lens, it tries to create value within the functioning of the hospital also by looking at different aspects. So improving the efficiency, use of generic medicines, how much tests are being, what is the length of stay, all these things ultimately lead to value. And another very good illustration of how value-based spending can lead to value in the outcomes of the health systems is reflected in this graph, where we see that how much is the level of spent between different countries and how much is the amenable or avoidable mortality in each of these countries. So generally speaking, there is a reduction. So as you keep increasing the level of spending, you have better health outcomes, you have lesser and lesser avoidable mortality. But you can see that there are differences between countries. So countries at the same level of healthcare spending may have different levels of health consequences or the amenable mortality, which means that there is something beyond just the overall value amount of money that you spend, but it is also about how you make those allocations, what are the things that you spend on that results in the value that you are able to derive from this money that you are spending. And one of the things that leads to creation of more value-based health systems is health technology assessment. And this is something that was discussed very in great detail yesterday during the panel discussion. And there were speakers from Thailand and UK and Australia who spoke on the value of health technology assessment for creating more bank for the buck that we spend. And also that even in the pandemic situations, there is a value for considering value-based pricing. You need to, so you'll be talking about how much should be the price of the tests. We are saying how much should be the price of the vaccine. So we know that these are, emergency situations, you need to make decisions, but ultimately the prices should be determined by how much is the value being offered by those treatments, or how much is the value to the health consequences of each of those healthcare interventions. And this is my final, point, that we need to be better prepared for pandemics. There's been a lot that Dr. Chandrakant said during his last lecture, but I think one of the key, side effects of the current pandemic was that all the other health services were, the delivery of all the other health services was ignored. And this is just one analysis that we did for provision of outpatient care for cancer. And we see that there is a steep reduction in the levels of healthcare utilization during the periods immediately after the onset of the lockdowns. And if we try and model that what could be the health consequences of these delays in treatment for cancer, and only looking at cervical cancer, just one of those cancers, we see that there is impact of that in terms of the disability adjusted life years and the life years lost and the excess deaths that happened just because of the delays in treatment that happened as a result of putting in those restrictions and all those things. So preparing for future pandemics, and with a lens of affordable healthcare, we need to ensure that there are systems that help to ensure that there are no more negative externalities of these pandemics. So this was the final message that I wanted to give. Thank you very much, and I'll be happy to answer more questions during the discussion.
Thank you so much, sir, for such a lovely presentation. Now I would like to request our chairperson, sir, Dr. Narendra Saini, to please give his valuable comments.
Now, this was an excellent presentation by Dr. Prinja. Am I audible?
Yes, sir.
Okay. So I know Dr. Prinja from his post-graduation days. He was one of the top postgraduates at that time also. And even now he has given an excellent presentation. So one thing which I want to highlight is that I think the point which is not touched by our politicians in our country is the issue of population control. Now, till the time we make some emphasis on this aspect of population control, we can go on planning the affordable health services, but we can go on putting in the resources. But in some years, we'll be falling short of resources, and then we'll have to start all over again. So I think this is one point which must be taken into consideration by our politicians and health planners, that we need to do more for controlling our population. Since we are at present, we are the second most populous country in the world, and we are shortly going to overtake China. So this is one thing which is going to, because the most important thing which Dr. Prinja has highlighted, the first point, that is increase in health spending. So we can go on increasing health spending, but there is a limit that we can spend on health. So till the time we control our population, I don't think simply increasing the health spending will suffice. Now, if anybody else wants to ask any question, I think we can ask.
So we have a question in chat box.
Yeah,
Uh,
Dr. Shweta, can I ask a question?
yeah, sure, sir, sure.
Yeah, my question is to Dr. Prinja. Thanks for an excellent presentation. Dr. Prinja, I would like to ask you that you talked about OOP, and this OOP mainly is whatever schemes we are running is covering the inpatient treatment. How can we reduce the outpatient treatment, which becomes a major chunk as far as a normal person is concerned? We don't have any scheme to, except for the generic drugs. What other mechanism could be developed? Because you see, the IPD is only 10%. 90% of the people are spending money from their pocket for outpatient treatment. So what mechanisms are there to mitigate this issue?
Sure, sir. I think that's a very pertinent point, sir. And one of the reasons why people feel that even insurance schemes have not been able to reduce the out-of-pocket expenditure is precisely the same, that the benefit package of these insurance schemes only focus on the provision of hospitalization care, and outpatient care is not included within the ambit of most of these insurance and almost all the insurance schemes. Now, the reason for non-inclusion of outpatient care is the multiplicity of providers that exist for provision of outpatient care. So in our country, the healthcare, which is so vastly unregulated, and there is so much of fragmentation and provision of healthcare, the providers for outpatient care can range from even a chemist, where the person may go and get over-the-counter medicine, to a quack, to a corporate hospital or a public sector facility. So if the outpatient care was to be included as part of the package under the insurance scheme, they would have to have huge empanelment of providers, which is going to be a very challenging task. And that is why none of the insurance schemes has been able to actually include the provision of outpatient care under its ambit. So the most low-hanging fruit for provision of outpatient care is to expand the capacity of primary health care. And primary health care should not be looked at only as a point of care where you are providing immunization and checkups for the pregnant women. Primary health care also incorporates outpatient care for a range of different basic diseases. And as a result, the focus of the government to augment the capacity of the primary healthcare to make it more comprehensive at the level of health and wellness center, to me it appears is the first step towards covering the large plethora of outpatient care that exists, the need for which it exists across the communities. So that is the most tangible and the most easy and doable part that the government can possibly do to cover the outpatient care.
Can I add to, and you talked about the screening of diabetes and hypertension, and you talked about that provision of care at these centers as far as these diseases are concerned. Now, as far as I have seen the training program of the CHOs, I don't find any training material largely attributed for training of CHOs on treatment of hypertension and diabetes. If that is not included, then how can we be able to provide the drugs? And if the drugs are provided, whether they'll be used scientifically, judiciously or not? That's a question point.
Sure, sir. So I agree with you, sir. There is a learning curve for any new program, and there would be certainly difficulties in initial implementation. But I see that there are a lot of state-specific variations in the curriculum of CHOs. So CHOs in quite a number of states that I've seen, they have Ayush doctors and staff nurses also as people who are being recruited. There are the way that the CHO has been, the community health officer has been conceived to provide the care is that the initial prescription is actually provided by the PHC medical officer, and then the subsequent provision of routine medicines takes place at the level of and the monitoring of the blood pressure and the diabetes takes place at the health and wellness center. So I'm sure that maybe initially there would not be as significant an uptake to begin with. So currently the level of utilization at subcenters is less than about 1% for the overall curative care. So even to take it to 5% or 10%, it will take a humongous effort. I completely agree with you. But the gains of that are very significant. So there has been an example in Tamil Nadu, even prior to the onset of, so the comprehensive primary healthcare program was preceded by two pilot programs that were launched in Tamil Nadu and in Kerala. The Tamil Nadu program was the pilot that was done in 2 districts, was primarily looking at how the primary healthcare, the sub-center levels can be strengthened for provision of these types of care. And there was a transformative change in the utilization of services at that level, simply by ensuring that there are adequate number of human resources at that level, and there is a sufficient regular provision of drugs that are available. So with these 2 things in place, they were able to see that there were 2 things that happened. A, it led to a shift in the care provision from tertiary and secondary level to primary level. And 2, it also led to a shift from the private sector to the public sector. So we have seen, sir, that even, for example, when the NHM investments came and they started to prioritize provision of institutional delivery for public sector, we saw that there was a tremendous increase in the jump in the coverage of institutional delivery. And that shift in the institutional delivery took place not just from women who were earlier delivering at home, but also women who were earlier going to private sector started coming to public sector. There were a number of other incentives that were also created. So the point that I'm trying to make is that given the adequate amount of investments and the adequate amount of human resources and supplies, the public sector has a capacity to deliver. And so that pilot from the Tamil Nadu state is again a reinforcement of the same kind of message that we are likely to get.
Thank you. Thank you.
Okay, any more questions? Any of the other who are attending this webinar can ask their questions?
So I can see that there is a question in the chat box which says that can public-private mix of healthcare delivery ensure equity in the long term? So just to respond to this question, I think that in general, the private sector, if you look at the levels of equity in the utilization of healthcare between the public and the private, generally the access to private healthcare systems is conditional on the ability to pay, because you need to pay something to access care at the private sector, in the private sector. So in principle, if you have a private sector provider, the access to care is linked with the ability to pay, and the moment that you link access with the ability to pay, the outcomes can never be equitable, because only the rich people would be able to access that and the poor people would not be able to access that. The only way that the private sector service utilization can become equitable is if the government purchases care on behalf of the population from the private sector providers. That's the only way. And this is what the government tries to do in schemes like PMJY. It tries to purchase the care for the population from the private sector. But the question then remains is, how much is the capacity of the government to regulate the private sector to ensure that the overall objectives of reduced out-of-pocket expenditure, no balance billing taking place, no frauds, no excess utilization, that is taken care of. So while it is good to think of, and obviously we can't turn a blind eye towards the large private sector that exists and it will continue to provide healthcare. We need to recognize that there are challenges when we start to engage with private sector for provision of healthcare, both from the point of view of equity objective and the financial risk protection.
So any further queries?
There's a question on vaccine efficacy, credibility, but I think it's beyond the scope of this lecture, I guess. So I'll pass it on to the organizers later on to answer this.
Yes. Sir, since we are running short of time,
Okay.
so
Okay, so thank you so much, Dr. Prinja, for this nice presentation. I hope the participants much have gained from this. So thank you so much.
Thank you, sir.
with this, we conclude this session. It's always a pleasure to listen to Dr. Shankar Prinja. Thank you, sir.
Thank you.
राम राम।
बहुत दिन के बाद शेव कर रहा हूँ, तेरा स्मार्ट आदमी बन जाऊँ।
अच्छा ठीक है।
तो उसके बाद आपसे बात करता हूँ। मैं पहले से ठीक हूँ, फीवर वगैरह नहीं है, थोड़ा सा स्ट्रेंथ वाइज इट इज गेटिंग बेटर। तो मेरा मन अंदर से किया एक तो हॉस्पिटल का राउंड ले लूं, वेलकम में उल्लू का पट्टा हूँ, फिर मैंने कहा अच्छा चलो शेव कर लेते हैं उसके बदले।
राउंड लेने नहीं जाना है अभी,
है
राउंड लेने नहीं जाना है अभी भैया।
अरे कौन जा रहा है हफ्ते भर यार, 10 दिन नहीं जाऊंगा, 19 तक कोई राउंड, 20 तक कोई राउंड नहीं
है ना। अभी तुम ससेप्टेबल हो
तो मैं करने के बाद आपको फौरन रिंग कर रहा हूँ सर।
ठीक ठीक,
थैंक यू।
ओके। हाँ जी, क्या हाल है?
ठीक है।
सब ठीक है?
ठीक है।
क्या हो रहा है?
ठीक हो गया। ठीक महसूस हो गया।
चलो ठीक हो जाओगे।
ठीक हो गई है।
चलो वो लगाया, कपूर लगाया कि दवाई डाली है?
क्या लगाया?
कपूर लगाया कि दवाई डाली है?
नहीं दवाई डाली है, कपूर तो तब लगाता है ना निकला हो।
चलो ठीक है,
निकला तो
दवाई से आराम आ गया?
दवाई से आ गया आराम।
चलो ठीक है, डालते रहो उसको, हफ्ता भर डाल लेना।
अच्छा दवाई कितनी बारी खाई दी है? दवाई तो
3 बारी।
Hello, Dr. Harivansh Chopra, please mute yourself.
तो बोलोगे ना now 10 marks goes to P. आगे आ जाओ मैं नहीं मैम तीनों दिख रहे हैं और भी अच्छा
आगे बताओ। साला जिस दिन बुला उस दिन आएंगे नहीं, 3 दिन से कह रही हूँ, 3 दिन से आया, 3 दिन से आया नहीं। तभी फिर गुस्सा आता है। ये बीना को हालात को देखो यार, BEE है।
ओके यार ये इतना कंजस्टेड होके अपने बैठ जाएगा, कोई नहीं, ठीक है। ब्लिंक करेगी वो।
अच्छा अब आ रही है आवाज।
बेवकूफ बना रहे हैं।
गाने गाने गाने
नहीं आएगी।
हाँ, there is no problems at all.
आपस में दो डिवाइसेस होते हैं ना, तो एक दूसरे
So
स्टार्ट कर दो।
एक कोई बोल दो यार कि जो टीम
So the latecomers have arrived. We were waiting eagerly for Team C. So now all the teams have joined: Team A, Team B, Team C, Team D, and Team E. So,
we had our presentation at the same time, so we were.
so you could have exchanged it. Because this thing was already informed to you when you are having the quiz and when you are having your sessions. All the teams were, and we all were eagerly waiting for you. So now we are going to start with the quiz. So important thing is that this is an online quiz which is going on. So all the teams will be muted, and the team which is going to answer will unmute and then speak up the answer so that there is no disturbance at all. Right? We don't want to listen to your discussions. We just want to listen to the answer. Time limit is already shown on the slide. Maximum 30 seconds or 40 seconds will be given to you for answering, right? So this is in general, which we are talking about the quiz. And now let's formally start the quiz. अभी पीपीटी ऑन होने दो, अभी बनाते हैं इंट्रोडक्शन.
मुबलिन शक्ल ऑन कर लो.
नहीं सर, हम तो ऑफ ही रखेंगे. मैम भी सुंदर है, मैम क्या है? सच तो सच है. जवाब सच है. अच्छा उसमें मैम हम नहीं आते.
So now we are going to formally start the quiz. The instructions are all the teams will keep the videos on. Keep yourself muted until unless you are asked to speak or it's your turn, right? And I don't want to see any mobiles in the screen to minimize the bias of cheating from you people. Although it cannot be minimized, but still you have 3 people to discuss. So I hope a great team effort will help you to go ahead and find out the answers and tell it correctly. So Pandit Bhagwat Dayal Sharma University of Health Sciences, Rohtak, Haryana, welcomes you for International Medical Sciences Academy Conference 2020. Heart and soul of Imsacon, you all very well know Dr. Ramesh Verma and Dr. Vinod Chayal. Because of their great efforts, we all have united over here, and we are almost running on the final session of this conference. And the backbones of Imsacon are Dr. Meenakshi Kalhan and Dr. Varun Arora. Without their efforts, this would not have been possible. And I don't have the photograph of the postgraduate students of Department of Community Medicine. And special thanks to the postgraduates of Department of Community Medicine who have put in a lot of efforts, and the senior residents who have put in a great effort to bring it to a great success. So with the words of thanks, I proceed further for quiz time. So this is quiz time. You all must be waiting. This is the most fun part of the conference, and I hope you all enjoy this time. So we all are sitting like owls in front of our screens and going ahead to look for the answers. and the questions. So we are the contributors. Dr. Kamal Singh and myself have prepared this quiz wholly and solely. And score managers for Imsacon quiz are Dr. Pratibha and Dr. Aman. And along with the score managers, they have helped us a lot in completing this quiz. Am I audible and the screen is visible to all? You all may unmute yourself and please tell.
Yes, ma'am.
Yes, ma'am. Team C.
Yeah, ma'am. Screen is visible.
Yes, ma'am.
So before we proceed for the round, so let's introduce yourself. First, team A will introduce who are we people talking to.
Dr. Vikram, Dr.
Yes,
Sonu, Dr.
Hello,
Kuber,
Dr. Sonu.
and Dr. Kuber.
Dr. Kuber. अमीर आदमी है यार तू तो मेरा नाम ही कुबेर है चलो next team, please mute yourself, team A, so that there is no disturbance. Team B.
Dr. Anirudh.
Welcome, Anirudh.
Dr. Manjula.
Welcome, Manjula.
Dr. Deepika.
Dr. Deepika, you are all from which departments?
Department of Community Medicine from BPS Kanpur.
So all of you are from community medicine from Kanpur.
Yes, ma'am.
Okay. So we all welcome you. PGMS Rohtam welcomes Kanpur. So team C is?
I am
Team
Dr.
C?
Rohit. Yes.
Dr. Rohit.
Ma'am, Dr. Priya.
Dr. Priya.
Dr. Riya.
Dr. Riya. Okay. So we have Rohit, Priya and Riya or Meenal?
Ma'am, Meenal was not well, so she could not attend this quiz.
So the participant has changed. So Priya and Riya is there. So you all are from which department?
Ma'am, Department of Medicine, STT Hospital.
So you all are from medicine department.
Yes, ma'am.
Okay. So Riya ne Meenal ki proxy lagai.
Ma'am, she was honest at least. She didn't say she was Meenal.
That's okay. So now team D.
I am Dr. Redler.
So Dr. I'm not able to hear you. Hello. इनका इंटरनेट में इशू है probably. Team D, I'm not able to hear you. Please unmute yourself, and you may remove your masks. If you are maintaining social distancing properly, you may not use masks.
I am Dr. Redler.
Ezil Larson. That's such a different name which I have come across. Can you tell me the meaning of your name?
It's a beautiful Arasan meaning king. I'm from Tamil Nadu.
So we are talking to King from Tamil Nadu.
It's the meaning of my name. I'm not.
Okay, welcome Ezil Larson. Next one is from team D.
Dr. Vandana.
Dr. Vandana, welcome Dr. Vandana.
Dr. Sonam.
Dr. Sonam. And you all are from which department?
Community Medicine, SHKM, Mewat.
So you all are from community medicine. Okay. So now team E.
This is Dr. Arup Shah from Department of Community Medicine, PGMS Rota.
I am Dr. Karan from Department of Respiratory Medicine, PGI.
Dr. Rohan Madan, Department of Ophthalmology, PGMS Rota.
तो सारे रोज के इकट्ठे हो रखे हैं चलो so with this introduction we go ahead for round 1. So now this is the round which will take you to your school time knowledge of biology, and this round is called as back to basics, and the tip from quiz master is fortune favors the bold. So it's better to answer, better to speak rather than keeping mum. So you have to keep in mind that there will be 10 questions. So it will be running in 2 rounds, 1 question for each team. It's a non-passing round and it will run in a clockwise direction. It will start with team A. Team A will get 30 seconds to answer. And once you tell the answer, if the answer is correct, plus 10 marks will be given. If the answer is not correct, then no marks will be deducted. So if this is just to make you comfortable, more or less, it's like an icebreaker, right? So should we proceed? Team A, Please unmute yourself.
Able to hear, ma'am?
Should we proceed?
Yes.
Okay. A normal person uses how many muscles to take one step? 40, 55, 125, or 200?
No.
Timer is running. Just take care of time.
200 D.
D.
So you have answered D. Your answer is correct. So you use 200 muscles to take one step. So now it's time for team B to unmute. Team B has unmuted. Okay. Now the question for team B. A pair of human feet contains how many sweat glands? A, 2500, B, 75,000, C, 2,50,000, D, 12,50,000.
B.
C.
D.
D for dog, D for Delhi.
12,50,000.
12,50,000. So answer is wrong. It's C. A pair of human feet contain 2,50,000 sweat glands. So you must be knowing. Now you must check how much basics are strong of you people. So now the question for team C. Team C, unmute yourself. The question is, how many square feet is the surface area of adult human lung? 250 square meter, 450 square meter, 350 square meter, or 650 square meter?
B 450.
B 450. So answer is wrong. It varies from 540 to 810 square feet. It's more or less like of a tennis ground. So हमारे basics बड़े ही खराब हैं. So now team D, unmute yourself. The question is, human foot constituted by 26 bones forms how many joints? 25, 28, 33, or 38?
33.
33 answer is C, and this is wrong answer. So 30. Oh, sorry. Answer is C, 33. Correct. The answer is correct. So 33 joints are formed by. So हमारी team, इस team के basics थोड़े ठीक हैं. Now for team E, unmute yourself. The question is, what is the name of recently discovered fifth basic taste? Unani, Kadadi, Umami, or Kamasi?
C.
C, Umami. Yes, this answer is correct. So plus 10 for team E. So with this, we finish with the first part of round 1. Now we proceed with the second part of round 1, which will be a true-false round. So we proceed with team A. नहीं अभी स्कोर नहीं, अभी तो ये राउंड खत्म हो जाएगा, उसके बाद हम स्कोर पे आएंगे. So team A, unmute yourself.
Yes, ma'am. Yeah.
A human brain cell can hold 100 times as much information as the Encyclopedia Britannica. True or false?
Human cell can hold 100 times as much as information as Encyclopedia Britannica. True for super. True.
Wrong answer. It can only hold only 5 times as much information as the Encyclopedia Britannica. इतना बोझ मत डालो यार अपने दिमागों पे. 100 टाइम कैसे होल्ड कर सकता है हमारा ह्यूमन ब्रेन? Now for team B. Team B, unmute yourself.
Yeah, ma'am.
It takes food 7 seconds to get from your mouth to your stomach. True or false?
Time is running. Only 15 seconds are there.
Be fast.
False.
Should I take it false?
False. Yeah.
Wrong answer. Marks को देख के घबरा गए तुम लोग. This was true.
Okay.
So now next team, please unmute yourself, team C. The average healthy mouth produces about 300 ml of saliva each day.
False.
False. Correct. So average healthy mouth produces about 600 ml of saliva each day. Now for team D. Team D, please unmute yourself.
Yes, ma'am.
When are you looking at someone? When are you looking at someone you love? Your pupils dilate, but not when you are looking at someone you hate. Is it true or false?
False.
Correct.
Correct.
When pupils, they also dilate when you are looking at someone you hate. Probably your pupils are dilating when you are looking at me. So, so we proceed to team E. Team E, please unmute yourself. If human eye was a digital camera, it would have 576 megapixels. True or false?
True.
Please
True.
repeat.
True. True.
True. Correct answer. So इसमें तो probably the person is from ophthalmology, so he has used his knowledge of ophthalmology.
Rohan. Oh, sorry. Rohan, you are from I, na?
Yes, sir.
That is why you could answer.
Thank you, sir.
Luckily, you got the chance to answer. Good.
So with this, we finish our round 1. I hope you enjoyed it. And now scores, please. And I'm stopping to share my screen, and our scorekeepers, our score masters will share the screen with you, and they'll tell you how much you have scored in this round. So our scores are team A has scored 10 points. Team B has not opened the khata till now. And team C has scored 10 points. Team D and team E have scored 20 points. So good luck to team B. So I hope that you score better marks in next rounds. So our scorekeepers, please stop sharing the screen so that we may proceed for the next rounds. So we proceed with round 2. Are you able to see the screen? Am I audible to you all?
Yes, ma'am.
Okay.
Show thumbs up.
So this round is called as the connect. As we know, as we can see, you need to connect the findings and tell something. So in this round, there will be 5 questions, 1 for each team. It will be starting from team B. It's a non-passing round. And with one question, there will be 4 subparts of the question. So first, you have to identify the disease. We'll be showing you some pictures. You have to connect those pictures and you have to tell which disease it is. And then subsequently, there will be 4 questions related to the disease. So when we'll be showing you the pictures to identify the disease, you will be having 15 seconds to answer. And once you correctly identify the disease, then we will be proceeding for the next 4 questions related to the disease, right? Plus 10 for correct identification of disease and plus 10 for each correct answered question related to the disease. If you are not able to identify the disease, then 10 marks will be deducted. We'll be telling you the answer of the disease and then the question will be asked related to the disease. Is that okay? Are you clear with the instructions? Are you clear with the instructions?
Yes, ma'am.
We'll be showing a screen. उस screen पे कुछ photos होंगे. You have to identify the disease first in 15 seconds. If you are able to identify, then plus 10. If you are not able to identify, 0 marks will be given. We'll be telling you the answer and then 4 questions will be shown to you, right? And in these 4 questions, you have to answer in 30 seconds and 10 marks for each correct answer. No negative marking is there. Should we proceed for the round? So we'll be proceeding with team B, right? So this is an example. And for example, in this picture, you can see 3 things. You have to connect these 3 pictures in 15 seconds. You can see the timer running on the top. Right, when 15 seconds are over, this is the answer. This is Cri-du-Chat syndrome, crying, dew, and chat, right? So this is how, in the similar fashion, the questions will be displayed to you.
Is the sample. Okay.
Is that okay?
Okay, ma'am.
So should we proceed?
Yes, sure, ma'am.
So team B. Time starts now.
Very fast part.
Steven.
Yes, team B.
Steven Johnson.
Right. Right. Correct answer. This is Steven Johnson syndrome. So plus 10 for this. Now we'll be asking the questions on Steven Johnson syndrome. And you have to answer 4 questions in 30 seconds. Right? 30 seconds timer will be running. And you have to answer all the 4 questions in the 30 seconds duration. Is that okay?
Okay.
Sure. We proceed with the questions. Organs predominantly involved in SJS. Time is running. If you don't want to answer, we can proceed with the next question.
Muscles.
Muscle.
Wrong answer. Steven Johnson syndrome is which type of hypersensitivity reaction? Your time is running. You may pass it so that we can. Okay. So you are not able to answer in 30 seconds. So this round is null and void for you people. So you have received only 10 marks. So the questions were organs predominantly involved in SJS are skin and mucous membrane. SJS is type 4 hypersensitivity reaction. More severe form of SJS is known as 10. And drug of choice for the treatment is Chalo, koi baat nahi. They'll find out the answer. Now we go ahead for the team C. Is team C ready? Unmute yourself. And the question for you people is this one. Horner syndrome, correct. So you have to answer the questions in 30 seconds. So you may pass the answer questions if you don't know the answer at that time. Is that okay?
Yes, ma'am.
Okay. So we proceed to the question part, Horner syndrome. The typical symptoms of Horner syndromes are seen in which organ?
Eyes.
Correct. Name any two components of this classical triad.
Meiosis and hydrosis.
Correct. Name any one test for the diagnosis.
Yes, टेस्ट होता है ना Horner syndrome का.
Schirmer eye test.
Schirmer eye test for the
Correct. Which lung tumor characteristically associated with this syndrome?
Pancoast tumor.
Correct. So this is how you have to perform. So 40 marks for this round plus 10 for the correct answer. So 50 marks to this team. Very good. Now we proceed to the next team. Please unmute yourself.
Yes, ma'am.
Team D, unmute yourself.
Yeah. Yes, ma'am.
So this is your question.
Conference route. Conference. Corridor.
Your time is up.
Okay. And
Would you attempt to answer?
no, ma'am. Not able to identify it.
Unable to identify. So this was carpal tunnel syndrome. Carpal and tunnel. So car or tunnel se we identify kar sakte the. If you are new people and I are not able to identify the pals. So
Okay.
this is carpal tunnel syndrome. So you will not get 10 marks for this. Now we proceed with the questions on carpal tunnel.
Okay, ma'am.
So first question, which nerve is involved in carpal tunnel syndrome?
Median now.
Correct. Which part of hand is involved in this syndrome?
This is the flexor retinaculum of the wrist joint and
Not retinaculum. Retinaculum का paralysis कैसे होगा भाई मेरे?
which part?
Next
question.
Next, name the tendons which are not affected in this syndrome. Next is name one test used for diagnosing it.
Card test.
Card test is okay. For question 3, we don't grant you any answer. We don't grant you any marks. And for question 2, we don't grant you any marks. So you get 20 marks for this round. So team D has scored 20 marks for this round. So now we proceed with next team. Team E, are you ready?
Yes.
Yes.
Wolf Parkinson.
Wolf-Parkinson
Wolf
syndrome.
This is Wolf-Parkinson's White syndrome. Wolf-Parkinson's White syndrome. So plus 10 for Wolf-Parkinson's White. Now we proceed with the questions on Wolf-Parkinson's White syndrome. The type of inheritance in the familial form of Wolf-Parkinson's White syndrome is?
Autosomal dominant.
Autosomal dominant.
Name the drug contraindicated in this syndrome.
Spironolactone, atropine.
No. Drug of choice for this disorder is?
Amiodarone.
Repeat.
Amiodarone.
Wrong. Typical ECG finding of WPW is short PR is?
Short PR with the delta.
Wrong answer. So you have scored only 10 marks. 10 marks for the correct identification of disease and 10 marks in the question answer round. So plus 20, right? So now team A, this is for team A.
Guns क्या है? गन आर्मी
गन नहीं है, गन नहीं है.
गन तो नहीं. Peace.
Time is up. Time is up. So would you like to attempt?
Yes, sir.
Huh?
क्या होगा गन?
So you don't have the time for this much time. So this is basically Huntington syndrome. Now be prepared for the question answers of this Huntington syndrome, right? Huntington's disease. So the questions on Huntington disease is type of inheritance of this disease is
Autosomal dominant.
correct. This is inherited by mutation of which gene?
Autosomal. Next question.
Next.
Which part of
The
brain?
part of brain which is most prominently affected in early HD is
Central area of brain.
Central area of brain.
Central area of brain. Huh?
Central area of brain.
Central area of brain specifically. Okay, next question is only medication specifically approved for this diseases.
Tetrabenazine.
Time is up. Time has already been up.
Abhi 18 seconds remaining. Tetrabenazine.
नहीं repeat चल रहा है timer. This timer is running repeat. ये timer चलता रहता है. I am looking at the timer, right? So you have scored 20 in answers and you have not told the you have not identified the disease. So plus 20 for team A, right? So with this we finish round 2. I hope you are enjoying it.
Ma'am, query from team E. The first question regarding Wolff-Parkinson-White, we had answered autosomal dominant, right?
Wolff-Parkinson's-White, yes, you have answered autosomal dominant, right?
In the last one, ECG changes, we also mentioned the delta wave.
So that also
time was up.
Okay, fine. But first question was right, no, ma'am. So
the 20 marks to you. One is identification of Wolff-Parkinson's-White plus 10 for this identification of autosomal dominant.
Okay, we had a doubt about the delta wave.
Okay.
Yes. No. Don't have any doubts.
Clear all doubts.
So I hope you have enjoyed this. And now we go ahead to our score masters again. That is scores, please. So I'm stopping to share this and asking them to share. हाँ बोलो.
मैं यही से बोल दूँ ना आप एक नोट करो अपने. One thing I would stop करो ना. Speaker. One thing I would like to share this thing. Then the students, whosoever is graduated from this college, must be knowing that when Dr. Aarti is there, you should not keep any kind of doubts with you. Thank you.
So, नहीं पूरी screen पे ही है. So for now we have to look at the scores. For round 2, team A has scored 20 marks. Team B has opened up the khata. Bank account has been opened with 10 marks. And team C has scored 50 marks. Great performance. Team D has scored 20 marks and team D and team E are running parallel. दोनों ने कुछ हिसाब किताब बिठा रखा कि हमें बराबर चलना है. So both are have scored 20 marks in both the rounds, round 1 and round 2. So this round is for community medicine people. We have 2 teams, one from Kanpur, one from Mewat, and one from PGIMS also, where we have community medicine people sitting.
Round is for all.
But this round is for all. but we have community medicine people sitting over there, so they may score high in this round. So this is the round based on our national health programs. We are not underestimating the others, but still. So what you have to keep in mind is there will be one national health program question for each team. We will be starting from team C. So one national health program will be for one team, and in that there will be 4 questions regarding that national health program, right? So it will be non-passing round, 10 seconds to answer each part of the question, plus 10 for correct answer, and no negative marking is there. So are you clear? Are you clear?
Yes, ma'am.
You can show thumbs up if you're clear. Right. So should we proceed with team C?
Yes, ma'am.
So identify the logo to which national health program it belongs to.
Janani Suraksha.
So time up.
Janani Suraksha.
This program is, identify the program. This program is, you don't know the answer, we proceed to the next. Any 2 services provided under ICDS are. So this program was ICDS, so we will not able to grant you the answer for that. So which any 2 services which are provided under ICDS?
Vaccination.
We are not able to listen, team C.
Supplementary education.
Are we audible, ma'am?
Team C, I'm not able to listen to you.
Ma'am, are we audible?
Yes, you are audible.
Ma'am, preschool education and supplementary nutrition. Ma'am, you are.
Okay, next, who are the beneficiaries under this scheme? Any 2?
Children under 5. Children under
less.
Pregnant and lactating mothers and children.
Correct. In nutrition and health education service under the ICDS is handled by which ministry?
Ministry of Women and Child. Ministry of Women and Child Welfare Development.
Correct. So you have scored 30 marks in this round. Right. So identify the program as ICDS. I don't think we need to tell the answers to you people because most of the answers are correct. So now we proceed with the next team, team D. Team D is ready?
Yes, ma'am.
Sure. Identify the logo. Time is up. Identify the logo. Abhi bhi bata do yaar.
Name. No idea.
Okay, this is midday meal program.
Okay.
So no attempt. What does the orange color represent in this logo?
Time.
No idea.
No idea. And which states have confirmed the supply of milk through schools in this scheme?
Tamil Nadu and
No.
Okay.
First Indian state to initiate the noon meal program?
Karnataka.
Huh? Speak.
Karnataka.
Wrong answer. So team D has not scored any marks in this round. So answers are, this program is midday meal scheme. Orange color represents the food plate. The orange is representing the food is served hot. And Karnataka, Madhya Pradesh, Haryana, Puducherry and Gujarat have confirmed the supply of milk. And first Indian state to initiate noon meal program is Tamil Nadu. Right? So now we proceed to team E. So 0 marks is awarded to you. So team E is for this. You don't have to identify this logo because ये अपने आप ही बताता है. This is on immunization. So we'll be asking you questions on immunization. So team E, first question is, the 2 major milestones of universal immunization program have been elimination of which diseases in India?
One is polio.
One is polio.
Other one is neonatal tetanus.
Correct. Next is beneficiaries for administration of TD vaccine are
pregnant women in the 2nd trimester.
That's all.
Chalo, half is correct. Next is name the diseases for which vaccine is given only in endemic districts in Haryana under the program. Should we proceed to the next?
Yes, next.
On 25th December 2014, who launched Mission Indradhanush?
Narendra Modi.
नरेंद्र मोदी नहीं है भाई, हर जगह हर जवाब नरेंद्र मोदी पे नहीं खत्म होता. So this is wrong. So you have scored 15 marks plus 10 for the first correct answer, and half of your second answer is correct. So third and fourth you have not answered correctly. So you have scored 15 marks plus 10 and plus 5 for question number 1 and question number 2. So we proceed to the, now comes the turn of team A. So team A, this program, we don't need to identify this program. This is obviously NTCP. हाँ, हमने नहीं पूछा है, अगले सवाल पूछेंगे हम, अगले सवाल बताओ. On NTCP, we are going to ask you 4 questions. The question 1 is, when was NTCP launched?
13 जुलाई के आसपास है.
कौन से साल में हुआ था भाई?
साल पूछ रहा.
चलो नहीं पता, आगे चलते हैं. Which country has complete smoking ban since 2005?
Countries.
2006 नहीं, 2006 भी गलत जवाब है. Which country has complete smoking ban since 2005? Name the country.
हाँ, 5 बार वो 6 हो जाएगा. यही होगा.
Which is next question is, which is first smoke free Indian state?
State है भी.
कोई ऐसा स्टेट है ही नहीं तुम्हारे हिसाब से, सब सुट्टेबाज इकट्ठे हो रखे हैं. When is no World Tobacco Day celebrated?
हिमाचल प्रदेश में.
No, not at all Himachal Pradesh. When is World No Tobacco Day celebrated?
When a World No Tobacco Day? जुलाई में है, जून में, जुलाई 30 जून. 30 जून या जुलाई. 30 जून या जुलाई.
31 मई.
31 मई.
अब पहले 30 जून बोला.
नहीं मैम, मैं कंफ्यूज
डिस्कस कर रहे थे हम.
पहले 30 जून बोला. एंड
टाइम कर रहे थे, डिस्कस कर रहे थे, आवाज सुनिए आपको.
Quiz master is final.
So
फ्रेंड्स का बर्थडे
नहीं, अब बर्थडे बाद में मनाना. So we are not giving you any credits. So team A has scored 0 in this round.
एक भी तो आंसर.
So we proceed to team B. Be careful whatever you speak. You unmute yourself when you need to speak up your answer, right?
Okay.
So team B, be ready. This round, the question belongs to pulse polio, probably the most easy, maybe the most difficult for you people. The questions are, in which year pulse polio program was launched?
1996.
Wrong. World Polio Day is celebrated on? Who developed oral polio vaccine?
Sachs and Sabin.
Which one? Salk or Sabin?
Sachs.
Huh? I'm not able to hear you clearly.
Salk and World Polio, Salk.
Salk, wrong answer. Countries with active polio?
Pakistan. Afghanistan.
Pakistan, Afghanistan, correct. Any two. So 10 marks are granted to team B because first it was launched in 95 and 24th October is World Polio Day, and who developed OPV is Albert Sabin, and countries with active polio are Afghanistan, Nigeria and Pakistan.
D on the video.
Team D has I'm not able to see the people of team D on screen, so please come on screen, don't go here and there. You have beautiful faces, although with masks, but still we would like to see you.
Ma'am, actually, can we join from some other link? Battery is down from my phone, so we have to join from the other link.
अभी तो हमारा राउंड खत्म हो गया है, तो we can you can use this link from any other device. आप अपना email ID उसमें डालिए जो भी laptop या mobile है, and then you join with this link only. And by the time we go ahead for the scores.
Charger is at home.
So what you are doing here?
We are in the college.
We are in the college library, ma'am.
Stop share करना है मुझे. Stop share.
Actually, not able to join and from other. Can we leave from here?
No, don't leave if you are not. Okay. Okay, first we have to leave, only then we can join.
Okay.
Yes, you have to leave and then join.
Okay.
So the scorers are doing the great job, and we have 0 for team A and team D in this round, and team B has scored 10 marks, team C has scored 30, and team E has scored 15 marks. रोहन छुप के बैठा हुआ है कि मुझे कोई देख ना ले.
या वो जो दूसरा है वो ज्यादा आ रहा है स्क्रीन में.
और Arup has taken up lots of space, right?
Yeah.
Yeah. That we can understand. So please, which team has left? Team D has left?
No, ma'am, we have joined from the other
mobile.
Team D has left right now, so we have a time left, so we can enjoy by the time. Stop share.
Ma'am, we have joined back.
Ma'am, we have joined back. Team D.
Let them join back.
No, we have joined.
Team B has joined back, ma'am.
They have joined back. Okay, Jitesh, thank you. Jitesh is keeping an eye on us.
Eagle eye.
He is an eagle eye of this whole conference. Everywhere Jatin is present.
Jitesh.
Sorry, Jitesh is present. मैं हर बार इसका नाम confuse हो जाती हूँ. Every time he is there.
His name is so slippery, na?
Jitesh Satija. So all the teams have joined back. A, B, C, D. I'm not able to see team A, team B, team C, team D, and team E. 858 attendees we have.
Dr. Aarti, ma'am, you are muted right now. Okay. Okay.
Good morning, Dr. Jitesh.
Good morning, Dr. Rohan.
So, are you able to see the screen? All the teams are able to see the screen?
Screen is visible for anyone. If anyone cannot see, kindly raise your hands. Yes, it's visible to all.
Okay. So the next round is on medical ethics. That is the most important part of our profession, which we need to take care, because not the machines are in our hands, lives of people are in our hands. So this is the time where there are some times where you need to make some critical decisions, and at some places you're confused whether to take this decision or not. So this round I have kept for people because this is a postgraduate quiz. So this is the time for you people to learn all these things so that you carry forward in your careers. So this quiz is medical ethics. So this is an auction round. Although we are talking about ethics and still we have kept it as an auction round. There will be one question per team. It will start with team D. We'll be showing you a scenario on screen. After the display of the scenario, team will bid points. If the team answers the question correctly, team wins the bid points. If the team is not able to answer the questions correctly, then half of the bid is deducted from the score. It's a non-passable round. And important thing is that bid is compulsory, so you have to attempt the answer. It's not like you can go let it go. Otherwise, all the people sitting over here may say, "Ma'am, we don't want to bid." So the thing is, bid is compulsory. Minimum bid limit is 10, and maximum bid limit is 30. And time limit to answer the question is 30 seconds. Are the instructions clear to you all? Team D, please speak up.
Yes, ma'am.
So are you clear about the instructions? The scenario will be displayed to you on screen.
Yes,
Then you
ma'am.
have to bid some points between 10 to 30. If
Okay, ma'am.
you answer the question, then after that, the choices will be shown to you.
Okay,
And
ma'am.
then you have to pick the correct choice. If you pick the correct choice, then you will be winning the bid points. If your answer is wrong, then half of the bid is deducted from your score.
Okay,
So you
ma'am.
have to bid between 10 to 30. So
Okay,
we
ma'am.
proceed with team D. So for team D, the question is, a 64-year-old man is admitted to the hospital for the treatment of bacterial pneumonia. The treating clinician forgets to ask about the allergies, and the patient is unaware that his severe allergy to penicillin is not known to the treatment team. The patient receives a dose of intravenous penicillin and suffers an anaphylactic response, but is successfully resuscitated by a medical team.
We bid for 30.
So how many points you are going to bid for?
30.
30
maximum
marks?
points.
Maximum points you want to bid for this? Okay.
Yes.
So team D has bid for 30 marks. अगर सही जवाब नहीं दिए तो 15 नंबर टोटल स्कोर में से कट जाएंगे. ठीक है?
Okay.
ठीक है. So now the choices are, if you want to look for the statement is again shown to you. 64-year-old man admitted to hospital with bacterial pneumonia. उसको पेनिसिलिन की एलर्जी थी. पेशेंट को पता नहीं था कि उसकी एलर्जी के बारे में ट्रीटमेंट टीम को नहीं पता. Patient receives a dose of IV penicillin and suffers an anaphylactic response, but he is successfully resuscitated by the medical team. Now the choices are, which of the following is most accurate description of the medical error? Slip resulting in a near miss, a violation resulting in a near miss, a lapse resulting in an adverse event, violation resulting in a patient injury, a non-preventable adverse event.
Violation resulting in patient injury, D. Violation resulting in patient injury.
Violation resulting in patient injury, D. Answer is wrong. So 15 number ka nuksan. So be careful while you bid. So this is lapse resulting in an adverse event. Because adverse event has happened, patient had allergic reaction, but that was successfully resuscitated. So this is an adverse event. And it was a lapse because it generally involves failure in memory. And if you want me to explain it to you, I can read all the choices. If you don't want me to explain, I can skip. Should I read out all the choices for you people?
No, ma'am. No, ma'am. You can skip.
Okay. बेचारे दुख में हैं. दुख सहन नहीं हो रहा.
Please tell, ma'am.
Please tell. Okay. Rohan want to learn medical ethics.
Ma'am, ethics are very important, ma'am. Basics of our.
That is why I have kept this down.
Yes,
so
ma'am.
lapse is an internal event that generally involves a failure in memory. A slip can be thought of as actions which are not carried out as intended or planned. For example, injecting a medicine intravenously when you meant it to give it subcutaneously. So slips are observable. Lapse are not observable. They are a failure in memory. It is the disease or the action which is happened in the question. It is an adverse event because patient had anaphylaxis. It would have been a violation if you would not have followed the policy. अब इसमें तो डॉक्टर को पता ही नहीं था कि उसको एलर्जी है, वो भूल गया in fact. A near miss is an event which does not produce patient harm, but that harm is not produced because God was there, because of intervening factors or good fortune. Otherwise, मरीज को नुकसान हो जाता. So this is not a near miss because मरीज को नुकसान हुआ और वो resuscitate कर लिया गया. And it was a lapse because it involved failure in memory of the treatment team. So this is not a slip, not a lapse, and it is an adverse event. So should we proceed to the next team? This is how the questions are coming to you. अगली टीम पे चले? So this is for team E. On second day of joining as first year surgery resident, attending surgeon asks him to obtain informed consent from a patient for a surgical procedure. Now it's time to bid. How many points would you like to bid? Unmute yourself first.
30. We will bid 30 points now.
So we will be bidding सब जुआरी हो रखे हैं. 30 points you want to.
Ma'am, if we don't know this should actually help us कि मतलब गलत किया है कुछ, इसलिए maximum should be bid on this one.
हाँ, तो नुकसान उठाने के बाद आपको पक्का याद रहता है, गलती करने के बाद. चलो ये छोटी गलती तो याद हो जाएगा. That's a good thing. Yes, okay, that's good on you.
Doing something is always better than doing nothing.
Yeah.
Yes, sir.
Chalo. So you have bid 30 points. So again we are showing you the statement. On second day of joining as first year surgery resident, attending surgeon asks him to obtain informed consent from a patient for a surgical procedure. आपका दूसरा दिन है, आपको informed consent लेने के लिए बोला गया है. The choices are: at this time, the resident should obtain the consent and answer any questions that he feels able to answer at this time. Obtain the consent and tell the patient to talk to the attending surgeon later if he or she has any questions. Obtain the consent and then research and answer the patient's question at a later time. Ask the attending surgeon to get the consent from patient himself or ask the nurse to get the consent from the patient. क्या करेंगे आप?
D, ma'am, D.
You will?
Before?
Ask the attending surgeon to get consent from the patient himself.
You ask the attending surgeon to get the consent. अरे यार PG होके तो ऐसे बोल देगा, surgeon को कि consent खुद लो.
Ma'am, if there was an option which said कि I can research everything about the case and then tell the patient, because we have to inform everything before taking the consent from the patient.
Yeah, very good, very good. Answer is D, very correct. So जीत गए हैं ये जुए में, 30 नंबर मिले हैं. So the first year resident should ask the attending surgeon to get the consent from the patient himself. मतलब हम लोग जब PG join करते हैं तो we feel hesitant to say these things to our seniors, but ethically you should ask your seniors to tell you all these things, or you first read out the risks and benefits of the surgery for which the patient has been planned for, and then take the consent, right?
He has been taught by Jaykrit Bhutani basically.
Sure. So now we go ahead for next team. Is the next team ready? Chalo. Team A. An 84-year-old team A, unmute. An 84-year-old man with cancer who is receiving chemotherapy and pain medication tells the doctor that he was told that death from the cancer is very painful. Please unmute yourself. Team A.
Yes. Okay.
He then asks the doctor if he can have extra pain medication if he needs it in future. Now it's time for bidding.
He then asks the doctor if he can have extra pain medication if he needs it. Cancer who is receiving chemotherapy pain medication to the doctor, he was told that the process is very painful. 30.
30 number. Very good.
थोड़ी स्क्रीन नीचे करा दी लाइट.
हाँ, तुम्हारे चेहरे पे ना रोशनी नहीं आ रही, अंधेरे में दिखाई दे रहा तुम्हारा चेहरा. तुम रोशनी की तरफ मुंह कर लो. हाँ, शाबाश.
आ गई.
एक रहेगा.
Now it's time for bidding, and they have bid 30 points. And this is the question again. 84-year-old man with, or should we go ahead directly before the options?
No, ma'am, question please.
Okay. 84-year-old man with cancer who is receiving chemotherapy and pain medication tells the doctor that he was told that death from cancer is very painful. Then he asks the doctor if he can have extra pain medication if he needs it in future. वो extra pain medication के लिए बोलता है कि मुझे extra pain medication दे दो
दे सकते नहीं तो
कि क्योंकि कैंसर से डेथ जो है वो बहुत पेनफुल होती है, तो प्लीज मुझे एक्स्ट्रा पेन मेडिकेशंस दे दो. तो the options are, at this time the physician should tell the patient that it is unethical to prescribe high dose of pain medication, ask the patient what else he was told, assure the patient that his death will not be painful, reassure the patient that he can have as much pain medication as he needs, tell the patient that not all cancer patients experience extreme pain. What you are going to do? अभी तो हमारी चॉइसेस हमने पढ़ी है ना, इसलिए हमको अब
डी नहीं आएगी, ई आएगा,
बी और ई में से कुछ
ई आएगा,
कौन सा ये नहीं होगा, एंड फिर उसको क्या मतलब है,
ई आएगा,
बी आई थिंक.
10 seconds to go, please answer.
डी.
नहीं
Be sure, lock it फटाफट.
डी.
बॉम्बे और दिल्ली? दिल्ली रॉन्ग आंसर. ऐसे थोड़ी बोल दे यार मरीज को कि जितनी मर्जी मेडिकेशन खानी है खा, बिकॉज तेरे को कैंसर है. ऐसे नहीं होता है. So the physician should ask. पहले वाला आंसर ठीक था यार तेरा, तो अब लड़ो आपस में. So the physician should first ask the patient what else he was told. Doctor can then address all the patient's concern about his illness and then its management. ऐसे थोड़ी है कि आप उसको बोलो कि जितनी मेडिसिन तेरे को चाहिए उतनी मर्जी खा ले.
नहीं हो सकता.
नहीं, दिल्ली. तो भैया दिल्ली के चक्कर में बॉम्बे का रास्ता.
दिल्ली में आजकल किसान आंदोलन की वजह से रास्ता जाम है, तो
अगली बार बॉम्बे जाएंगे.
तुम जा तो ठीक रहे थे, बट चलो कोई बात नहीं. पर लेकिन अब तुम्हें नुकसान बहुत गहरा हो गया. 30 नंबर तुमने बिड किए थे, 15 नंबर कट गए हैं.
पहले कुछ नहीं है,
कोई बात नहीं, अब उनका नुकसान है. We can't help it. So now the next team is ready.
Team C.
Team B.
B.
So at an evening going away party, a 40-year-old physician drinks 10 glasses of beer. पार्टी करी, 10 ग्लास ऑफ बियर पी लिए. The physician then gets a page to go to the hospital. हॉस्पिटल में बुला लिया. Despite the fact that a colleague tells him not to go, the physician says, I am fine. नहीं मैं ठीक हूँ, and leaves for the hospital. Now bid the points.
Only experienced persons can go for.
Bid the points, team B. 20. So they are playing safe. कि 10 का ही नुकसान होगा. अगर नुकसान हुआ तो
Do you drink beer first?
So probably they know.
फिर वो सही बता रहा है.
So should we proceed to the? You have bid for 20 points. Are you sure? Sure. 20 points you have bid for.
Speak louder.
So the choices are: at an evening going away party, 40-year-old physician drinks 10 glasses of beer. A physician then gets a page to go to the hospital. Despite the fact that a colleague tells him not to go, the physician says, I am fine, and leaves for the hospital. What is the most appropriate action for the colleague to take? Chase the physician and physically restrain him. Report the physician to the hospital ethics committee the next day. Report the physician to the State Board of Medical Examiners as soon as possible. Ask to speak to the physician alone as soon as possible. Immediately notify those in charge at the hospital that the physician is likely to be impaired. So what you would like to do? D for Delhi.
E for elephant.
E for elephant. Are you sure?
Sure, ma'am.
E for elephant. Yes, the answer is correct. Because rest all other choices, you cannot physically restrain the physician, and it's unethical to report to the hospital ethics committee because he has not done anything wrong till now. And similarly, no point in reporting to the State Board of Medical Examiners. And similarly, there is no pointing to speak to the physician when he is impaired. So E choice is correct. So they have scored the bid points. So 20 points are added to team B. So ऐसा भी हो सकता है. So the next question for team C. Team C, please be ready. This is the last question. A 42-year-old HIV positive man is admitted by your first year PG student for hematuria, which is most likely from a kidney cancer. He is DNR. DNR means do not resuscitate. Urology department is consulted and they think a kidney biopsy is in order as well as a possible nephrectomy is to be done. However, your PG student does not want to do either one because the patient is DNR and therefore pre-terminal. How many points would you like to bid on this?
2-0.
2-0 points you would like to bid. Good choice. So 20 points they have bid. So do you want to read me the statement again?
Ma'am, can you please repeat the last line? After this, however, your PG student does not want to either one because the patient is DNR and therefore
Pre-terminal. Pre-terminal means he is about to die.
Ma'am, the last line is not visible because the patient is DNR and therefore below this we are not
Pre-terminal. Pre-terminal. नहीं तुम्हें तो दिख रही है. Pre-terminal. Pre-terminal. Should we proceed for the choices?
he does not want to do either one.
So these are the choices for you people.
Yes, ma'am.
What should you tell him? आप अपने PG को क्या बताएंगे? Being DNR must mean that patient is pre-terminal and just about to die. Patient who is DNR should not get the routine care such as biopsy or surgery. चिड़ियाओं को भी डर लग रहा है यहाँ पे. Patient cannot undergo surgery or placed in ICU if he is DNR. And DNR just means that physician should take the cardiopulmonary arrest as the end point of the therapy, or silently tell your PG that it doesn't really mean if the surgery is successful, so DNR is kind of a relief for you. What are you going to do? Team C. No, actually both.
Ma'am, D. D for dog.
D for dog, D for donkey. Okay. DNR just means that the physician should take the cardiopulmonary arrest as the end point of therapy. This is the correct answer, correctly chosen. And DNR only means that physician should take the cardiopulmonary arrest as the end point of therapy. Before cardiopulmonary arrest, any kind of illness patient is having, patient deserves the treatment, patient deserves the investigations, patient deserves the surgery, patient deserves the care. Even if he is HIV positive, even if he is pre-terminal, but DNR only means physician should take the cardiopulmonary arrest as the end point of therapy. So with this, and a quote for you, जिंदगी तुझसे हर कदम समझौता क्यों किया जाए, शौक जीने का है मगर इतना भी नहीं कि मर मर के जिया जाए.
Wow.
So with this,
Wow, nice, ma'am.
thank you so much for the applause. This is for you people. And now scores please. So I'm stopping to share my screen and our scorers. Let our scorers. Quiz is enjoyed. Imsacon ki feeling is enjoyed by the birds also. So now the scoreboard is shared. Team A नुकसान में है, 15 नंबर कट गए हैं. Team B, Team C and Team E have scored good marks. Team B has scored 20. Team C has scored 20. Team D has scored -15 in this round, and Team E has scored 30 points. So I hope you enjoyed this round. I kept this specifically so that you may have some learning, probably you may have some sensitization along with the fun. So with this, we proceed to our next round. Should we begin with the next round 5? Should we begin? Yes or no? Please speak up. Yes or no?
Yes, ma'am. Yes, ma'am.
Chalo, we are beginning with this next round. So after thoda sa ethics and thoda sa knowledge part, we are now having an entertainment round. So I hope you enjoy this round too. This is on basis of your about general knowledge, not general knowledge specifically, but डॉक्टर बनने के बाद डॉक्टर्स के दो ही शौक होते हैं, एक बड़ा घर होना चाहिए, एक बड़ी सी गाड़ी होनी चाहिए. So घर के लिए तो हम कुछ नहीं कर सकते, गाड़ियों के ऊपर हम आपसे सवाल पूछ सकते हैं. And I wish कि जो जिस गाड़ी का आप सही जवाब दें वो गाड़ी आपके घर खड़ी हो. हाँ, so we are proceeding with the fun round. So let's know. So can you hear the audio in the PPT?
No. The audio is not.
जितेश गाना सुन रहा है क्या? सुन रहा है ना?
नहीं कुछ चलाओ, तुम चलाओ.
ऑडियो शेयर करने के लिए
स्क्रीन शेयर बंद करूं? 1 मिनट.
Lamborghini chalai.
Yes, the audio. We can hear the audio.
You can hear the audio. Chalo, should we are beginning this round. पहले गाना सुनाते हैं इनको पूरा, उसके बाद राउंड शुरू करेंगे.
Lamborghini chalai jane o, Lamborghini chalai jane o, सानू भी झूठा दे दो, किथे कल्ले कल्ले जाई जाने ओ, सानू भी झूठा दे दो, किथे कल्ले कल्ले जाई जाने ओ, मॉडल टाउन च मारे गेड़ी, मॉडल टाउन च मारे गेड़ी, सानू भी झूठा दे दो, किथे कल्ले कल्ले जाई जाने ओ.
So now we proceed to the instructions. कोई बात नहीं, हमारे इंटरनेट में कोई इशू होगा, कोई दिक्कत नहीं है. So there will be 2 questions and 1 song for each team. So there will be a picture shown to you and you have to identify the car and उससे रिलेटेड एक सवाल आएगा और जो कार आप आइडेंटिफाई करेंगे उस कार से रिलेटेड आपको एक गाना गाना होगा. अगर आप वो गाना गाएंगे तो आपको 10 नंबर मिलेंगे. तो पहले 2 सवालों के भी 10-10 नंबर प्लस एक गाना गाने के भी 10 नंबर. अगर गाना नहीं गाएंगे तो 10 नंबर नहीं मिलेंगे. सो टोटल 30 नंबर का राउंड है. 2 सवाल है, माइनस भी है. सो 2 क्वेश्चन प्लस 1 सॉन्ग. ठीक, तो 30 नंबर. और हर सवाल के लिए आपको 10 नंबर करेक्ट, हर सवाल के सही जवाब के लिए 10 नंबर मिलेंगे और सही जवाब नहीं आया तो 5 नंबर काट लिए जाएंगे. ठीक है, गलत आया तो -5 फॉर रॉन्ग आंसर, 0 फॉर नॉट आंसरिंग and +10 for the correct answer. So are you clear about the instructions? Are you clear about the instructions? Please say yes or no.
Yes, ma'am. Yes, ma'am. Yes.
चलो भाई, टीम ई तैयार हो जाओ.
हमारे में क्लियर आ रही है स्क्रीन.
इंटरनेट का कनेक्शन हो गया क्लियर. दिस इज क्लियर. So team E, name this American car. 10 seconds to answer.
Ferrari.
Ferrari यार हद होगी, मतलब नहीं खड़े होगी तेरी गैराज में ये कार. Wrong answer. So who is the manufacturer of this car? Now you can tell by the logo. Who is the manufacturer of this car? यार हद है, मतलब तुम लोगों को कारों के बारे में नहीं पता. I was not expecting this. I thought this would be the most enjoyable round. So 10 सेकंड तो पूरे हुए, बहुत देर हो गई. अभी ने जवाब ही नहीं पता तो गाना कहाँ से गाएंगे?
मैम आंसर बता दो.
आंसर तो मस्टैंग है. गाना गाओ. मस्टैंग पे फोर्ड इसका मैन्युफैक्चरर है. अब मस्टैंग पे गाना सुना दो.
मिल जाएंगे 10 नंबर.
10 नंबर मिल जाए. गाना सुनाओ.
रोहन के पास तो वो है ना, होंडा सिटी है.
गाना भी नहीं आता तुम लोगों को? हाँ, दिस इज फॉर टीम ई. सो गाना हम सुनाते हैं तुम्हें. गाना सुनाओ.
गड्डी जट्टी ने रखी है मस्टैंग वे, जने खणे दा बजाउंदी फिर बैंड वे, तू चाबी चक मेरी कार दे.
मुंडा मुकरे ना जावे देखी सोहणी ट्राई लगे तेरी कार दी. ओ मुंडा मुकरे ना जावे देखी सोहणी ट्राई लगे तेरी कार दी.
चलो नेक्स्ट टीम. ऐसे करके हम सवाल पूछेंगे. नेक्स्ट टीम प्लीज बी रेडी. टीम ए, नेम दिस ब्रिटिश कार. टीम ए, नेम दिस ब्रिटिश कार.
ढंग से दिख नहीं रहा
मैम. लोगो तो नहीं पता चल रहा.
लोगो तो दिखा देंगे तो भाई.
गाड़ी देख के लोगों का अपने आप आइडिया लग जाएगा. आप ध्यान
हाँ, गाड़ी देखते ही पता लग जाता है यार.
रोल्स रॉयस.
Rolls Royce, wrong answer. Next is how many years ago this company was founded? अब तो बता दो. लोगो तो अब तो दिख गया.
लोगो देख के पता चल रहा.
हाँ, अब तो लोगो दिख रहा है. अब कितने साल पहले कंपनी फाउंडेड हुई थी ये बता दो.
कंपनी तो पता चले कौन सी है.
अरे बी उल्टा नहीं दिख रहा तुम्हें.
हम पहले आइडेंटिफाई का आंसर तो बताते हैं. आपने कहा था हम बताएंगे आंसर.
तो आंसर तो तुमने बताया ही नहीं.
चलो गाना सुना दो.
क्वेश्चन के लिए तो बताओगे आंसर.
आंसर तो बता दिया हमने. बेंटले. पहले का सवाल तो का हम क्यों बताएंगे जवाब यार, जब तुम्हें पता ही नहीं है. दिस इज बेंटले.
बोला तुमने.
अब मैंने तुम्हारी गैराज में इतनी अच्छी अच्छी गाड़ियां रखी थी रखने के लिए.
गाड़ियां हो गया. मैं क्यूज नहीं दे रहा हूँ. घर पे बैठा हूँ.
क्या
अब तुम ये बताओ, इस पे गाना सुनाओ. गाना सुनाओगे तो 10 नंबर और मिलेंगे.
मिल गए.
ये रहा. कौन है?
अरे नेट पे मत ढूंढो, तुम्हें ऐसे मिलेंगे नहीं गाने.
मैं सुना रहा हूँ आपको.
आपने गाना सुना दिया मैम. देखो
नहीं, नेट पे नहीं मिलेंगे.
आपने ये नहीं बोला कि मैम
and I may deduct 10 marks from your score for this work which you have done right now.
ये मार्क्स YouTube के
लेकिन ये गाने के नंबर नहीं मिलेंगे.
मैम आपने बोला था गाना सुनाना है. कैसे आपने ये नहीं बोला था कि आपने सुनाना है.
सुनाना बोला था भाई. सुनाना बोला था.
गाना सुनाने के लिए बोला था तुम्हें. सर्च किया तो तुम्हें फिर यहाँ क्विज अटेंड करने की कोई जरूरत नहीं है यार. This kind of shit is not tolerated over here. Now I am telling it on serious note. And you may lose your points on this. So no cheatings. I have initially told you don't keep your mobile phones along with you. So अब हम हंसी मजाक के राउंड में we don't need to have a serious माहौल. So don't do this again. And 0 for team A. And गाना हम सुनाएंगे तुम्हें.
-5 तो आएगा.
हाँ, -5 फर्स्ट आंसर इनका गलत था तो -5 आएगा. बाकी तो इनके ठीक ही थे. बाकी उन्होंने जवाब नहीं दिया तो उनके 0 आएंगे.
ਹਾਂ ਅੱਖਾਂ ਉੱਤੇ ਤੇਰੇ ਆਪ ਰਾਡਾ ਸੱਜਣਾ ਅਸੀਂ ਟਾਈਮ ਚੱਕਦੇ ਆ ਟਾਡਾ ਸੱਜਣਾ ਕਾਲੀ ਰੇਂਜ ਵਿੱਚੋਂ ਰਹਿਣਾ ਬੈਲੀ ਤਾਰਦਾ ਤੁਹਾਨੂੰ ਚਿਹਰਾ ਦਿਸਦਾ ਨਹੀਂ ਸਾਡਾ ਸੱਜਣਾ तेरे पिछे साख छड्ड आई 40 गोरी चट्टी को मैं बेंटली च काली पराडा अखां ला के देख ले
काली बेंटली क्यों लगा बेंटली मर्सिडीज मुझे पसंद है चलो आगे तो नेक्स्ट क्वेश्चन दिस इज फॉर टीम बी नेम दिस ऑटोमोटिव मार्क ये कौन सी कार है बताओ भाई
ये नहीं मेरा पार्ट है कुछ
ये सिर्फ किताबों में ही रह गए हाँ मुझे भी एक्सपेक्टेड था कि ये लोग जवाब दे देंगे
चलो तो साफ हो गया कुछ बोलने
तो तुम्हारे 10 सेकंड तो पूरे हो गए आंसर बताओ टीम बी कौन सी कार है भैया
मिनी
हाँ
स्पीक
अप
मिनी मिनी मिनी
आवाज नहीं आ रही
मिनी आगे सुनाई नहीं दे रहा बेटा
मिनी मिनी
मिन्नी आगे पूरा नाम
तो मैम
मिन्नी से आगे क्या है यार मिन्नी से आगे तो बहुत कुछ होता है
किसी चीज के आगे मिनी लगा दो तो मुश्किल हो जाती है
हाँ तो दिस इज null and void question for you ना नेगेटिव कटे ना नंबर कटेंगे ना नंबर मिलेंगे Answer is Mini Cooper. It is produced by.
Next question.
It is produced by. Mini Cooper is produced by. Time up. ये मेडिसिन सर्जरी की तैयारी करके आ रहे थे. This is produced by. चलो आंसर इसका मैं बाद में बता दूं तुम गाना सुना दो मिनी कूपर के ऊपर सुनाओ टीम भी गाना अब YouTube मत चलाना प्लीज और ऐसे मिलेंगे भी नहीं YouTube पे गाने
आंसर ऑफ टीम बी गाना आता है कि नहीं आता
गाना नहीं आता
स्क्रीन में दिखाऊं स्क्रीन में लगवा मेरे
It is produced by BMW.
आओ कर दूंगा सब्बे पूरियां नी तेरियां डिमांडां जेड़ियां मिनी कुपर ला दूंगा ओ विच बैठ के तुम्हारी गेड़ियां मिनी कुपर ला दूंगा विच बैठ के तुम्हारी गेड़ियां नी
चलो so we proceed to team C identify this car अब तो बता दो
Team C, unmute yourself.
Unmute yourself.
मैम लो
Speak loudly.
मैम लोगो
लोगो नहीं दिख रहा है
लोगो तो दिखाई नहीं रहे हम तो कार ही दिखा रहे हैं लोगो थोड़ी दिखा रहे हैं
पोर्शे
पोर्शे करेक्ट पेरेंट ऑर्गेनाइजेशन ऑफ दिस कंपनी
पोर्शे किसकी है
पोर्शे किसकी है
मैम वॉक्सवैगन की वॉक्सवैगन ग्रुप
करेक्ट करेक्ट आंसर गाना भी सुनाओ
ब्लैक पोर्शे
गाना गाना गा के
ब्लैक पोर्शे
गाना सुनाओ फटाफट नंबर कट रहे हैं तुम्हारे
ब्लैक पोर्शे
ब्लैक पोर्शे तो क्या है इसमें तो ग्रे पोर्शे दिख रही है
गाना
गाने के नंबर नहीं मिलेंगे तुम लोगों को चलो गाना हम सुनाते हैं तुम्हें
ਫਿਰਦੀ ਏ ਰਾਣੀ ਸੜਕਾਂ ਨੂੰ ਚੁੰਮਦੀ ਅੱਖਾਂ ਨਾਲ ਰੋੜ ਜਦ ਮਾਪੇ ਗੱਭਰੂ ਉਹ ਦੇਖਦੇ ਨੇ ਜੱਟ ਵੱਲੋਂ ਜਾਂਦਾ ਸ਼ੂਕਦਾ ਪੂਰੇ ਖੜ ਜੂ ਕਿਹੜਾ ਬਾਰਿਸ਼ ਦੇ ਵਿੱਚ ਕਿਹੜਾ ਇੱਕ ਹੀ ਉਹ ਬੱਚਿਆ ਬਥੇਰਾ ਤੇਰਾ ਟੂਣ ਦੇ ਤਾਂ ਖੜ ਕੇ ਤਾਂ ਕਰਦੇ ਗੱਭਰੂ ਕਿਹੜਾ ਲਵ ਬਾਰਿਸ਼ ਦੇ ਵਿੱਚ जेड़ा एक ही बचया बसेरा।
चलो टीम डी आइडेंटिफाई द कार, ये तो बता दो। टीम डी अनम्यूट योरसेल्फ। टीम डी
yes ma'am. Okay, Tata nano.
क्या एक्सपेक्टेड नहीं था कि तो पोर्च देखने के बाद टाटा नैनो आएगी। Correct answer. The next question is, name the Britain's largest automotive manufacturer which has become the part of Tata Motors.
Repeat again, ma'am.
Largest
Name.
automotive manufacturer part of that.
Jaguar.
Bit louder.
No.
Rolls Royce.
Wrong answer.
Okay, ma'am.
It's -5 plus 10 -5. So it's Jaguar and Land Rover that has been acquired by Tata.
First I have.
No, but he said first Jaguar only.
You said wrong answer.
Jaguar
You
तुमने
said
बोला
wrong
था?
answer.
Yes,
Yes,
ma'am.
Jaguar
Yes,
was.
ma'am.
Yes, ma'am.
You have said Jaguar.
Yes,
अच्छा.
ma'am.
Okay.
Okay.
गाना
गाना टाटा नैनो पे चाहिए हमें लेकिन. नैनो पे गाना.
सज्जना पे दिल आ गया कि सज्जना पे दिल आ गया.
अरे नहीं गाओ, एक आदमी गाओ.
हाँ गाओ गाओ शाबाश.
No, miss.
नहीं नहीं नैनो कार पे, तुम्हारी नजरों पे नहीं, नैनो कार पे. नैनो पे नहीं, नैनो कार पे गाना.
मैम नैनो वर्ड आ गया, मैम नैनो वर्ड आ गया.
So this is -5 for नैनो कार का सॉन्ग. नैनो कार का सॉन्ग मैं सुनाती हूँ, सुनो. ऐसे देखो.
आओ जट्टा दी ट्राली बने 3 लाख दी, किते महंगी कुड़े तेरी नैनो कार को. जट्टा दी ट्राली बने 3 लाख दी, ओ किते महंगी कुड़े तेरी नैनो कार को.
तो चलो भाई ये राउंड खत्म. इस राउंड में आपके लिए सरप्राइज है.
But for song you said there will be no minus. If you are singing the song only then you will get, but for song there will be no minus.
क्यों? I have told them कि song के लिए -5 will be there. अगर आपने सही गाना नहीं सुना है तो they will be -5.
Okay, ma'am.
आपने गलत गाया. आपने गलत गाया. गलत गाया नैनो पे गाना. क्यों गाया? The surprise is now. This is something which you need to rush for. जैसे सेल लगती है, सब भागते हैं पहले मैं. यहाँ पर एक बिड राउंड है. बिड राउंड में सिर्फ आपके पास 2 सवाल हैं. ठीक है, तो 2 सवाल है, इसका मतलब 2 ही टीम्स जवाब दे पाएंगी. 10 सेकंड आंसर करने के लिए मिलेंगे. जो बिड स्कोर आप करेंगे, जो बिड आप लगाएंगे, you will get the bid score if you correctly tell the answer. If you incorrectly tell the answer, you will lose 50% of the bid. Lekin who will get the chance? The highest bidder will get a chance to answer the question.
0.
Maximum bid can be the up to the point scored by the team.
Teams wise.
अब 3 bids लगाए टीम ए. So आप अगर आपको स्कोर जानने हैं उसके लिए तो हम स्कोर दिखा सकते हैं. आपका टोटल स्कोर टिल नाउ कितना है, जितना आप बिड कर पाए. टीम ए टीम राउंड 4 के एंड तक का टोटल कंप्लीट है. टीम ए हैज 15 मार्क्स, टीम बी हैज 40, टीम सी हैज 110 लीडिंग, टीम डी इज 25, टीम ई इज 85.
ये सी और डी में ऊपर नहीं चल सकता.
So now you know your scores. Highest bidder will get a chance to answer the question. Now bid. Team A, you can only bid 15. Team B can bid 40. Team C can bid up to 110. Team D can bid up to 25. Team E can bid up to 85. Yes, bid. Unmute yourself.
Team A 15.
Which team?
Team A 15.
Team
A.
Team A bid
15.
15 मैक्सिमम पॉइंट्स. ओके,
जुआ खेल रहे हैं पूरे पूरे.
इनके नंबर कटे नहीं, ये बदमाशी को उतर आए थे. टीम बी
30.
Team B, how much you would like to bid for this? Or
30.
Team B would like to bid for 30. So A will not get the chance. Team C
20.
20 you would like to bid. Okay. So Team C will not get the chance because Team B has already bid 30 points. Would you like to increase your bid, Team C?
No.
No. Team D? नहीं, इनके 25 नंबर है, बिड कर ही नहीं सकते. टीम डी के
करना है bid.
No, Team C has already bidded for 30.
30 points, so Team D cannot bid. Team E
20 points.
20 you cannot bid because Team C has already asked for 30. So Team B is playing on 30 marks.
All in all भी खेल रहे हैं.
नहीं, इनके 40 marks हैं. 40 में से 30 को उन्होंने दाव पे लगा दिया है.
क्या बात.
चलो. All the best to Team B. Now the question displayed to you is, this is the question. Three-wheeled micro car originally manufactured from 1962 to 65. It was listed in 2010 Guinness World Records as the smallest production car ever made. So identify the car. Time starts now. Team C. Sorry, Team B.
The Peel P50.
Shabash. Correct.
Wow. That's great.
So
30 नंबर जीत गए ना. 30 70 हो
30
गए.
40 जमा में 30 70 नंबर. शाबाश.
एकदम स्कोर अप हो गया इनका. दूसरे के लिए
So now for the next question you have to bid again. Now the points for Team B is 70. Team A stands at 15. Team C stands at 110. Team D at 25 and Team E at 85. Anybody wants to bid now?
Team A 15.
जुआ खेल रहा है. 50 15.
A 15 नंबर.
15 से पूरा सही नहीं चला करेंगे. 15.
Team B, would you like to bid again?
30. The same.
Team B ने फिर से 30 नंबर का जुआ खेला.
जो जुआ में जीता वही खेल रहे दोबारा.
Team C, would you like to bid?
20.
Team C नहीं, you highest bidder will get the chance. Either 30.
No.
Or 30 plus.
30 plus.
No bid.
No bid. For Team D के तो 25 ही नंबर है, वो तो बिड नहीं कर सकती क्योंकि उन्होंने 30 बिड किया है. Team E, would you like to bid?
अरे रोहन कहाँ सो गया तू?
Yes, we'll bid 40 points.
30 points.
40
points. You will bid 40 points.
उनसे पूछ लो 30 वाले से कि उन्होंने ऊपर तो जाना.
हाँ. Team B, आपके 70 नंबर हैं, वो 40 नंबर की बिड लगा रहे हैं. Would you like to bid more?
No, ma'am.
No. Okay.
Actually इनके पास आर पार की गेम हो जाएगी ना. Otherwise सीधे पार निकल जाएंगे. All the best to the Team E.
All the best to Team E. The question is, identify the car and sing the best suited song for this car.
The car is Ferrari.
शाबाश. गाना सुना दे यार.
मैम वो एक
आने दे.
आ जाना फरारी में, मैं हूँ तैयारी में.
आ जाना फरारी में, मैं तैयारी में.
मैं तो हूँ तैयारी में. होगा जब सनसेट कुछ ऐसा.
गा के सुना थोड़ी है.
Correct answer. Very good. So आप
-5 किसी के थे?
So your score, you are मतलब गाना हमने कुछ और चूज किया था आपके लिए, तो वो हम बजा देते हैं, but you have answered it correctly.
तेरा मेरा मेल मिले ना तो के फायदा इस यारी का. तेरा मेरा मेल मिले ना तो के फायदा इस यारी का. यार तेरा चेतक पे चले तन कसका रेड फरारी का. यार तेरा चेतक पे चले तन कसका रेड फरारी का. यार तेरा चेतक पे
scores, please. Now there is ups and downs in the scores. So this round has changed the scenario. So team E के garage में तो Ferrari खड़ी हो सकती है और P50 किसके garage में खड़ी होगी ये देख लेना भाई. So I'm stopping to share my screen, and I would ask my scorekeepers to please share the scores.
वो इससे ऊपर उठ गया ना जुआ खेल गए नहीं तो फिर तो गेम हार पाती.
So team A
नहीं टोटल लगाओ ना.
टोटल अभी हमने करा नहीं है.
टोटल लास्ट में अच्छा एक ही बार करोगे फाइनल स्कोर.
Total team A has scored -5 in this round. Team B has scored +30. Team C has scored +20. Team D has scored +15, and Team E has scored +35 in this round.
ऊपर चेंज करके नीचे ऑटोमेटिक चेंज आता है.
So all the team members, I would like to see their faces on the screen. Don't go here and there. This is an international conference and quiz is going on. You all are enjoying that. Doesn't mean you will break the rules. So I hope you may understand. Team C people, they.
अच्छा ये रिया के साथ ये दूसरी proxy.
Okay. So team C, should we proceed with the next round? Yes or no? Team A, B, C, D, all are ready. So the next question is prisoners of mobile phones. We all have become prisoners of mobile phones, and all the pictures they clearly depicted. So we have kept a round on this. So हो गया So the instructions for this round is there will be one question per team. The rounds will start with team A. It is a non-passing round. Time to answer is 30 seconds. There is +10 for correct answer. There is no negative marking. ठीक है? Should we proceed with the rounds? We'll start with team A.
Okay. You can show thumbs up.
Team A.
राउंड है 5 हुए हैं तो कोई ना अपने 15 मार्क्स अपने 5 होने नहीं चाहिए थे.
टीम A का है ना.
So this is an example. This is not to be answered. I have a habit of taking multiple pictures of myself. I enjoy uploading them on social networking sites. When my mother asks me to stay away from clicking pictures, I get impatient and irritated. APA has confirmed I have a mental disorder. So the answer is self-itis. So the questions will be coming like this. So there will be a statement and then you have to tell the answer. Is it clear?
Okay, ma'am.
+10 for correct, no negative marking. 30 seconds to answer. For team A, the question is, I have a habit of updating my status on Facebook and WhatsApp. I have the anxious feeling if I don't receive any texts or not able to send my any message. I have the feeling that no one loves me, no one contacted me, but I have.
Okay, 1 second, ma'am. Question तो
Question देख ले यार. Time हम अपना मोबाइल में देख लेंगे.
I am fit to uploading my status on Facebook. I have this feeling I don't receive text or not able to send any message or text. I feeling that no one love me, no one contact me, what I have. बताओ भाई.
मित्तल खोले नेट नहीं खुला
टाइमर हमारा पहले शुरू हो रखा है 10 सेकंड बचे हैं
24 दिखा रहा
अच्छा नहीं वो आगे वाला है
है अच्छा
नो
डिप्रेशन
no idea should we tell the answer
yes ma'am
okay so answer is text IT so they have not attempted this so this is text IT which people usually have now the next team team B please be ready
फिर छोड़िए तो कोई
unmute first team B the question is I experience finger cramping that come from constant gaming, scrolling, and texting on smartphone. Numbness in the ring and pinky fingers occurs when the elbow is bent for long periods of time. I have, time starts now.
सैंडविच खाने लग रहा है जो लेके आया था वो उसी लूट के गया था वो
होता है ना
Time is about to finish. Please, would you like to attempt the answer?
No.
Time is up. So it is also unattempted by this team. 0 marks. And the answer is cell phone elbow. ठीक है? So the next team C. Team C, please unmute yourself and be ready. I patted my back pocket and realized I did not have my phone. Seconds later, I patted my back pocket again. This time reaching for my phone in order to help to find my phone. I get fidgety when I don't have access to my phone. I get neurotic when my phone runs out of battery. What phobia do I have? Time starts now. Ten seconds left.
Nomophobia.
Nomophobia, correct.
Wow.
Team C.
Good.
Team C is really doing great. Team D, the question is, I can feel my phone ringing in my pocket, but when I check, there are no calls or text. I have a fear that I will mix a text. Somebody is trying to reach me and I'm not being responsive. Any stimuli or friction on my skin makes my mind believe that my phone is vibrating. What is the syndrome I'm suffering from?
Phantom mobile syndrome.
Correct. Phantom ring syndrome or phantom vibration syndrome. Team E has also performed. Sorry, Team B has also performed good. Now, Team E. The question is, I am enjoying first 6 months of second prof, but now I have started having headaches, torticollis, neck and shoulder pain. X-ray neck revealed a loss of normal cervical curve and with forward head posture. On reviewing, usage of mobile screen time was found to be 6 hours per day. I have what I have. Team E.
we're discussing.
Discuss. Time 10 seconds are left.
Cell phone cervical syndrome.
No. Wrong answer. Although no negative marking is there. This is called as text neck syndrome. So beware of using your mobile. I have told you 5 diseases at least, which you can suffer from overuse of mobiles. So with this, we finish our round and we ask our scorers to please share the scorecard. हाँ पता है. So in round 6, Team A and Team B have scored 0. Team C and Team D has scored 10, and Team E has also scored 0 marks. So with this, we are going ahead for round number 7.
रिजल्ट जो बनाएगा जोड़ना एक्सेल पे कर लिया होगा जब के अच्छा
हाँ वहाँ पे भी तो बता देंगे, खुद भी तो अपना स्कोरिंग उन्होंने वो करी हुई है. So now we come to round 7 and this is regarding how much you know about chest radiographs. We are into the chest radiographs.
Hide floating meeting control. हाँ.
So how much you know about chest radiographs? So we are in COVID time, all the PGs have gone through the COVID duties and the most common x-rays which they have gone through are the chest x-rays. So I thought we need to keep this round. So how much you know about your chest x-rays? Let's know the instructions. So there will be 5 questions. It will be an MCQ. We will start with team B. It will be non-passing round. We'll be having 30 seconds to answer. Scoring is +10 for the correct answer and -5 for wrong answer. It will be an MCQ which will be shown to each team. So 1 question per team. So are you clear about the instructions? Yes or no?
Thumbs up.
It will start with team B. Team B, are you clear? Should we proceed? Team B, should we proceed?
सांस तो लो.
Team B, should we proceed?
Yes, ma'am.
Chalo. So time starts now. This is the X-ray. Which finding is present on this image? Sail sign, meniscus sign, pneumothorax, or air bronchogram? Time is about to be up.
Bronchogram.
Huh?
Bronchogram, ma'am.
Wrong answer. So -5. Team C. So the answer is this is meniscus sign which has been shown. So answer is B. So now we proceed to the team C. Which finding is present on this detailed image of the left lung? Mesothelioma, asbestosis, pleural effusion, or calcified pleural plaques?
Speak up, be fast.
Calcified pleural plaque.
Correct. +10 to team C. So these are the calcified pleural plaques which you can see. So team D, a 20-year-old female has high-grade temperature and cough. Which answer best describe the appearance? Pleural effusion, lung cancer, consolidation, or image inadequate due to patient rotation?
Consolidation. Consolidation.
C, consolidation.
C,
Correct answer.
consolidation. Yeah.
So we proceed to the next team, team E. Patient has cough, weight loss, and finger clubbing. Which statement is true? Blunting of CP angle is due to pleural effusions. Lungs are hyperexpanded. Image is diagnostic of lung cancer, or image is diagnostic of asthma?
Lungs are hyperexpanded. Lungs are hyperexpanded.
Lungs are hyperexpanded. Lungs are hyperexpanded. Answer is correct. Team B. Answer is B. Correct answer. Team A. Which physical examination sign would you expect to be present at the time of taking this X-ray? Left-sided bronchial breathing, right side of chest hyper-resident to percussion, tracheal deviation, or finger clubbing?
B लग रहा है B. B है.
D for Delhi?
B for Bombay.
B for Bombay. Correct answer.
ये देख right side. मैं रुक जाता मैं इसलिए मैं चेक कर लेंगे
क्या चेक कर लेंगे यार, बिल्कुल ठीक जवाब था। मतलब हमारे जो पोस्ट ग्रेजुएट्स हैं उनको ऐसे वाला क्विज एक्सपेक्टेड था जहां पर हम उनसे मेडिसिन के सवाल पूछते, क्योंकि ये सवालों के जवाब तो ये दे रहे हैं, जीके जुके के सवाल इनको कम नहीं आता, और गाड़ियों का तो कतई शौक नहीं है इन लोगों को। सो आई वुड लाइक आवर स्कोरर्स टू प्लीज शेयर द स्क्रीन फॉर स्कोर्स। So in round 7, team A has scored +10. All the teams have scored 10 except team B, who has lost 5 marks. And scoreboard of team C and team E is looking glorious. And I hope all other teams, they do catch up in the coming 2-3 rounds more. So we proceed with our next round. That is round 8. And this round 8 is Google Doodle round. This is Google Doodle. So we are very well versed with the Google Doodles. When you are opening up the Google, a doodle is coming for celebration of something. So we have picked up some doodles for you, which are focusing on the persons who have contributed to medicine. So you have to identify those persons and their contribution in medicine. And again, there will be 5 questions, 1 question for each team. It will start with team C. It is a non-passing round. So 4 clues will be given. They will be coming one by one. In the clues, what you have to do is you have to identify the scientist and the contribution in the science. Time will be 10 seconds after each clue, plus 40 on answering at first clue, plus 30 on answering at second clue, plus 20 on answering at third clue, and plus 10 on answering at fourth clue. No negative marking is there. You have to tell 2 things: identify the scientist and the contribution in science. Okay. Time is 10 seconds for each clue. When there will be doubt, then we'll be discussing. So are you clear with the instructions? Should we proceed? Should we proceed? Team C. Team C. Unmute yourself. Should we proceed? Unmute yourself.
Yes, ma'am.
Sure. First clue is, she was a surgeon who studied the effects of anesthesia on newborn babies and their mothers.
हाँ जल्दी जल्दी 4 clue आएंगे मैम पास.
Next clue is, she was posthumously honored by the United States Postal Service with Great American Series postage stamp.
She was
posthumously awarded.
10 seconds are over.
Pass, ma'am, pass.
She developed the first standardized method for evaluating a newborn's health immediately following the birth.
God.
Speak up the answer.
No.
Would you like to pass to the next clue?
Pass.
Next clue is this. Identify the scientist and medical invention. This is the Google Doodle.
अपगार है इसका साइंटिस्ट का नाम बता दो.
Tell the answer.
Virginia Apgar.
Correct. What she has done is medical invention.
Yes, sir. Ma'am, assess the newborn. Yeah. At the time of birth, respiration, color,
That is called as
Apgar score.
Apgar score. That is called as Apgar score. So correct. So 10 marks are awarded to you. She is Virginia Apgar, and she has contributed Apgar score, and that includes appearance, pulse, grimace, activity, and respiration. So this is question number 1. So next question to next team. Next team is ready? Team D is ready?
Effect of anesthesia.
Team D थोड़ी आएगा. Team B.
C थी ना वो.
I don't know. The question is coming for team B.
Team D.
Just hold on. Hold on. There is some issue. Hold on. हाँ चेक कर लेते हैं ना हम.
D आएगा ना.
आना तो D चाहिए लेकिन.
तो ठीक तो आ रहा है.
टीम B आ रहा है ना ये.
गलत आ रहा है इसका मतलब.
B C.
इसका करेक्ट नहीं है. D.
E.
बोल दो B से होएगा.
फिर B के बाद C फिर थोड़ी आएगा कोई.
मतलब नहीं आएगा ना. तो C पहले आएगा ना.
तुमको बोल देना इग्नोर द टीम जस्ट आंसर. अब आंसर का क्वेश्चन तो ठीक है, लेकिन हम करें किससे? हमने शुरू किससे कराई?
C से किया ना.
C किया था. C को तो अनम्यूट करवाया था.
C को अनम्यूट कराया था. ठीक है.
तो टीम D से हमें आंसर करने हैं. इसको हम टीम D कर देते हैं. उन्हीं से पूछ लो कौन सी टीम आंसर.
मैम सी से स्टार्ट किया था.
हाँ मालूम है हमें C से स्टार्ट किया है.
डोंट यू वरी.
नहीं
अच्छा एक आंसर है. ठीक है.
पहले मुझे म्यूट करने दो. लेट मी म्यूट माय सेल्फ. So screen share हो गई. Unmuted भी है. So team C we have answered correctly. Now we proceed to team D. So team D first clue is his work culminated in 1936 publication of the book Specificity of Serological Reaction. Would you like to attempt on this?
Next clue.
Next clue. He and his friends studied on monkeys infected with syphilis and demonstrated spirochetes with dark field microscopy. Next clue.
Next clue.
He received Nobel Prize for his contribution, but he did not recognize the potential importance of his work when he wrote, "I hope this will be of some use to mankind."
Silver.
Next clue.
Yeah.
So this is the next clue. Identify the scientist and the medical invention.
ये तो वही है. Silverman.
Speak loudly. I'm not able to listen to you.
Silverman. Oh, Silverman.
Silverman तो नहीं है इसका जवाब. It's wrong answer. What are you thinking? Team D is scoring 0. So he is Karl Landsliner, and he was discoverer of major human blood groups.
Okay, ma'am.
Okay. So now we proceed to team E. Is team E ready?
Yes, ma'am.
So first clue for team E. Dutch physician who received the Nobel Prize in physiology or medicine. Team C, they come together. I want to see them in one screen. There has been a doubt. Some of the people and attendees have given us the comments. All the people of team C are not there in one screen. Team E, next clue is he made a device called string galvanometer, which was named after his name. Team E.
William Ethiopen for ECG, the Ethiopen triangle.
Correct answer. So they have answered on second clue. So plus 30 to team E. I was not expecting the answer. He is credited with being the eponym for the triangle in human body, in Einthoven's triangle and Einthoven's law of physiology. So he is Willem Einthoven. He invented the first practical ECG. Now we come to team A. First clue is English chemist who made important contribution to the structure of viruses. Next clue is her photo 51 and X-ray diffraction image of her unique genetic code was her most remarkable work.
Team A members are visible नहीं है team B.
Franklin. ठीक है बोल दे रोसलिन फ्रैंकलिन ठीक है ना
नेट पे देख ले यार ढंग से देख.
Team E, Rohan, where is Rohan?
Rosalind Franklin.
Rosalind Franklin is the correct answer.
Both hands.
Rosalind Franklin is the correct answer, and they have also correctly told the answer on clue number 2. So they have scored plus 30. So team A has scored plus 30 in this round. She died of ovarian cancer, and Nobel Prize in Medicine was shared by the discoverers of the genetic code. That is.
Team A members are also not visible.
So this is the Google Doodle. And this is the safe slide, and this is the answer. Before we proceed to the next question, I request all the team members to share one screen, because we have got the query from the organizers that all the team members are not visible.
Team A members, all members are not visible. थोड़ा ये स्क्रीन नीचे करो ना अपनी, तुमने स्क्रीन आसमान में चढ़ा रखी है. This is like now it's better. Chalo, next.
So next question is team B. Team B.
Yes, ma'am.
First clue is Indian American biochemist who created the world's first synthetic gene. हरिवंश राय बच्चन तो नहीं हो सकता.
जीनी अभिषेक बच्चन.
This is the next clue. He shared the 1968 Nobel Prize for Physiology or Medicine with Marshall V. Nirenberg and Robert W. Hawley. Who is he? Yes. And what he did in invention is?
Ma'am, yeast chromosome.
मैम जीन बनाया था बायोसिंथेटिक जीन.
वो तो हमारा उस इन्वेंशन के लिए उसको नोबेल प्राइज नहीं मिला. ये तो हमारा क्लू था. और कोई इन्वेंशन जिसके बारे में जिससे वो फेमस हुए.
मैम न्यूक्लियोटाइड पे रिसर्च था मैम इनका.
यस, न्यूक्लियोटाइड पे रिसर्च था उनका. सो दिस इज ग्रांटेड टू यू प्लस सेकंड क्लू, so plus 30. So very well played. So now we go to the scorers. How far we have reached in scores.
Video and audio बंद कर दो. Video बंद कर दो.
एक मिनट, stop share. Stop video. No. Let me tell them the score. So you are well versed with the scoreboard. Team A has scored 30, Team B has scored 30, Team C has scored 10, and Team D has scored 0, and Team E has scored 30. So now Team A is catching up. Team C is still gloriously winning. But I request Team C members to share one screen. Team D members also, where are the other members? I can only see, third is peeping in. So we proceed to the next round. Stop share. सेव क्योंकि इसमें हमने चेंजेस किए थे ना वो वाले
ये कहाँ है सारी पेन ड्राइव पे चल रहा है
लैपटॉप पे चल रहा है
वहां से वापस पेन ड्राइव कॉपी मारना सेकंड लास्ट राउंड
I would like to see all the members in one screen. Just like Team B is sitting. Team E has also managed. Team C has also now managed. Team D is not able to manage. Please somehow manage.
ये टाउ स्क्रीन पर सारा कुछ मेरे पास डिले है 1 मिनट जैसे YouTube पे कल डिले आ रहा था ना on YouTube चला ना
So is the screen visible to you all? Okay. So now we are on round 9. So this is how much you know our constitution, not your, how much you know our constitution. And I thought this is something which we know, which we should know, because now the time has changing and we should be well versed about the thing on which this nation is running. So we have 5 questions, which starts with Team D. You have only 20 seconds to answer, plus 10 for correct answer, and no negative marking will be there. For example, what is the constitutional name of India? So answer is the Republic of India. So this is how the questions will be coming, and you have to tell the answers. For Team D, should we start Team D? Okay. So for Team D, the question is, when did the Constitution of India come into effect?
1950, January 26.
26 January 1950.
Yes.
Correct answer. The next question for Team E. There was an additional information for you people. The original Constitution of India was handwritten, and it was handwritten by Prem Bihari Narayan Raizada under the chairmanship of Dr. B.R. Ambedkar. So ऐसा नहीं है कि Dr. B.R. Ambedkar ने लिखा था. जो लिखने वाले तो प्रेम बिहारी जी थे, लिखवाने वाले B.R. Ambedkar जी थे. For Team E, the question is, the fundamental rights is the major basic feature of Indian Constitution. This feature is borrowed from which nation?
French. France.
French Constitution. Okay. Wrong answer. This is USA. So this is incorrect. For Team A, liberty, equality, and fraternity are borrowed features of which nationality?
France. बोल दे रुक जा 9 seconds बोल दे France.
Answer is
France.
pass. Okay, they have not answered.
France, ma'am.
France. Okay. Correct. For Team B, the idea of single citizenship is taken from which country?
UK में single citizenship.
Team B.
The Britain.
Correct answer. Team C. Part 4A of the Indian Constitution, Article 51A, deals with
C. Team C. Unmute yourself.
Article 51A, fundamental duties.
Fundamental duties.
Article 51A is fundamental duties. So this finishes with the round of our constitution. So now the time for scores, and all of you have only one team has not answered the question correctly. Rest all the teams have answered it correctly.
तो तुम बता सकते हो, हम तो दो ही बंदे हैं, हमारे पास तो कोई नहीं। कोई बात नहीं, इंटेलिजेंट होते हैं ये तो एक्सेप्शनल इंटेलिजेंस है, स्टैटिस्टिकली सिग्निफिकेंट इंटेलिजेंस अभी लंका लगेगी।
एक मिनट, हमारी मीटिंग कहाँ चली गई?
है एक मिनट, क्या कर रहे हो? नीचे जाओ, नीचे जूम खोलो, नीचे जूम खोलो, ये हटा दो, इसको क्रॉस कर दो, इसको नहीं करो, हाँ उसको, हाँ ना क्रॉस 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 क्रॉस, हाँ मार्क्स को शेयर कर।
Team C, Team A has scored, all the teams have scored 10 marks except Team E, which has scored 0. So now we come to the last and final round of this quiz. And so this is the last and final round of this quiz. This round is on celebrities. And I would like to see all the team members in one screen.
Team C. Team C members, can you show all your hands? Team C. Third girl. Yes. कोई हाथ रहता नहीं क्या?
So there will be again 10 questions with one question for each team. And so there will be total 10 questions in this. There will be 3 clues, and we will be starting with Team E. And the question is, identify the celebrity and the medical condition which he or she suffers from. And again, time is 10 seconds to answer after each clue. If the team answers on the first clue, identifying the celebrity, on first clue plus 30, on second clue plus 20, on third clue plus 10, and plus 10 for identifying the disease which he or she suffers. So अगर disease नहीं बताते हैं तो 10 नंबर नहीं मिलेंगे, और clues पे identify कर लेते हैं तो first clue पे बताए तो plus 30, 20 and 10 depending upon the clues. So are you clear with the instructions? Are you all clear with the instructions?
Yes, ma'am.
Okay. With Team E, first clue is the celebrity is 1/3 of one of the most famous bands in the world.
Time's up.
Time is up. The next clue is he wrote a song called Joy to the World and was selected to appear on 2002 annual Broadway Equity Fights AIDS album. Time is up for next clue. So the next clue is, this is the childhood pick of the celebrity. Identify the celebrity and the disease which he suffers.
Type and diabetes, na?
Identify the celebrity and the disease.
Nicholas.
Nicholas
Time is up.
type 1 diabetes and Nicholas.
Time is up. Time is up already.
Nicholas बता दिया मैम type 1 Nicholas.
निक जोनास के नंबर मिल जाएंगे पर लेकिन डिजीज तो टाइम अप होने के बाद बताया तुम।
मैम type 1 diabetes बता दो पहले।
टाइप 1 डायबिटीज भी बता दिया था।
हाँ मैम पहले वो बताया था
पहले डिजीज बताई थी और फिर उसके बाद नाम बताया।
मैम वैसे हमने प्रियंका हस्बैंड भी बोला था।
Okay, granted. So now on the last clue they have told plus 10 for disease and plus 10 for celebrity, 20 marks for team E. So we proceed to the next team. Team A. The first clue is the celebrity has been recently more politically active by lobbying President Donald Trump for prison reform.
नहीं.
So next clue is launched a brand Skims which was previously called Kimono, but the name was changed due to immediate backlash. Next clue is identify. This is the childhood pick of the celebrity. Identify the celebrity and the disease which she suffers from.
इस लड़की का नाम क्या था? किमोनो ब्रांड वाला करता था। किमोनो ब्रांड किसका था? किमोनो ब्रांड सेलिब्रिटी का
डिजीज का नाम
Time is running short.
नहीं पता यार।
Time is up. Time is up. Still, would you like to attempt? Although we will not grant you points.
फिर नहीं करेंगे।
चलो।
किमोनो वाला तो न्यूज़ में आया था।
नहीं यार।
Okay, so we go.
नाम क्या दिया उसने?
We go ahead for the answer. She is Kim Kardashian, and she suffered from psoriasis. So team B. Team B. First clue is
Unmute.
Golden Globe Award winner and recipient of Academy Award for Best Supporting Actor in 2020. Next clue is in October 2020, he narrated on advertisement for Joe Biden's 2020 presidential campaign. Next clue. This is the early adulthood pick of the celebrity. Identify the celebrity and the disease from which he suffers from.
Al Pacino तो नहीं है ये।
Time is up. Would you like to attempt the answer, Team B?
Ma'am, Al Pacino.
Al Pacino, no.
Pacino.
यार तुम लोग बहुत ही नालायक लोग हो. How can you miss him? So I would like to. There has been some attendees which have requested the Team C people. The boy, member of Team C, please stand behind the two girl members and raise your hands. Show your hands empty. Some are saying that they are using mobiles. So I don't want any other controversies over there. Thank you so much. Thanks a lot.
And you keep standing there till the question. You just be there only.
So the question for Team C.
Unmute yourself.
Marilyn Monroe of Bollywood.
Unmute.
Unmute, Team C, unmute.
Unmute. Unmute yourself.
Is there negative marking in this?
Unmute.
No negative marking.
Malika Sherawat.
No. Wow. She played the lead role in the blockbuster movie which broke all the existing box office records in India and became the highest grossing film in 1960. The film is still the highest grossing film of all time if adjusted against inflation.
Mumtaz?
No. Next is, this is the early adulthood pick of the celebrity, Madhubala. Okay. Identify the disease which she suffered from. Time is up. So they have scored only +10. She suffered from ventricular septal defect.
Yes.
Okay. So we now go to next team, Team D. Team D. First clue is Beirut-born star is known for his jaw-dropping benevolence. While shooting off a film, he gifted his team of stuntmen, each a Harley-Davidson motorcycle. Who is he?
Team of stuntmen is Harley-Davidson motorcycle.
Arnold Khan.
Wrong answer. He founded a private cancer foundation, not in his own name, to provide research and assist Children's Hospital.
Next clue.
Next clue. This is the childhood pick of the celebrity. Identify the celebrity and the disease which he suffers.
There's a speed actor. He is.
Time is up. Would you still like to attempt? We will not grant you any marks.
I think speed actor or Matrix hero. I don't know.
No. He, अरे यार तुम लोग. He is Keanu Reeves and he suffers from dyslexia. John Wick तो देखी होगी यार तुम लोगों ने. अभी ताजा मूवी आई है. और मैट्रिक्स की रिलीज के बाद उसने अपने हर स्टंटमैन को मतलब हार्ले डेविडसन गिफ्ट की थी. And this was such a big news.
Okay.
So now to Team E.
Rohan and party.
In September 2015, he was appointed the brand ambassador for research in Rajasthan, a campaign by the state government of Rajasthan.
Rohan, unmute.
Yes, sir. कर लिया sir. Irfan Khan.
Irfan Khan is correct. And the disease? Disease he died from.
Men syndrome.
He died from?
Colon cancer. Colon infection.
Correct. So they have attempted on first clue and they have answered it correct. So plus
30 plus 10, 40.
Plus 40 plus 10. No, 30 plus 10.
30 plus 10.
40 marks. So he is Irfan Khan. So now we come to Team A. He appeared in 4 Marvel Cinematic Universe films, including an eponymous 2018 film that earned him an AACP Image Award for Outstanding Actor in a Motion Picture. टाइमर तो चल रहा है. हाँ, वो इस स्टेटमेंट खत्म होने के बाद I start counting the time. So time is. So next clue is his breakthrough performance came as baseball player Jackie Robinson in biographical film 42.
क्या ना? ओमरी हार्डविक.
Google देखा.
तुम लोग ना हाँ.
Team A, the member seeing the mobile, the rightmost person.
Right.
The person who is laughing now. Cheating.
Wrong answers. Although your answer was wrong, I have not made so easy quiz that you can answer in plus in 20 seconds or 30 seconds, but still you're attempting the cheating methods is not good.
Hello.
But still, you are not granted any marks because
We are
you
basically
attended.
anatomy people. You can very well understand what is the issue with us.
So answer is Chadwick Boseman. He died from colon cancer
Colon
recently.
cancer. Same.
So the next question to team B, इसके अंदर हमारी animation is not there. So
Escape कर देना करो. Escape.
कोई बात नहीं.
Clue तो देना.
अब उनके नंबर कटेंगे ना टीम बी पे. Animation is not there. Though 2 clues will be. कोई बात नहीं.
Animation डाल दो ना.
कोई बात नहीं. First clue is he was the director of the movie Barfi, which won the prestigious Grand Jury Award at Okinawa International Film Festival in Japan. And next clue is he played the role of Yamraj in recently released Amazon Prime movie. So with 2 clues, 20 seconds have passed. The next clue is attendees are calling. This is the early adulthood picture of the celebrity. Identify the celebrity and identify the disease which he suffered from. Who is he? Team B. Time is up. Would you like to attempt now?
No,
Team B, would you like to
अनुराग
attempt?
बासु. अनुराग बासु.
अनुराग बासु, आंसर तो ठीक है. अब कौन सी बीमारी से बचा है वो अभी?
लुकीमिया.
कौन से वाला लुकीमिया?
इतना तो इतना याद नहीं है.
But still we cannot grant you the answer because time was up. Anurag Basu, acute promyelocytic leukemia. So we come to team C. Again, 2 clues are being shown. So after receiving the Citizen of the World Award, the celebrity is relevant to 20 different countries in celebration. She undergone a double mastectomy as a preventive measure after
See, the male boy, please stand beside the girls again.
I don't. Team C, unmute.
Team C, unmute. The boy stand beside the girls.
Angelina Jolie.
Angelina Jolie is the correct answer. And नहीं second clue पे बताया उन्होंने.
नहीं मैंने तब से I've been seeking Angelina Jolie.
Okay. Identify the disease which she suffered from.
Breast cancer.
आपने second clue पढ़ा नहीं. इसीलिए अब तो आपका जवाब गलत है.
मैम कैसे?
मैम disease is Bell's palsy.
तब से बोल रहे हैं हम एंजेलिना जोली.
And you are saying breast cancer.
Bell's palsy.
No, you said breast cancer.
But ma'am, others were saying
Bell's palsy.
He was constantly saying Bell's palsy, but he was going backwards. That is why you couldn't hear him.
Because because the 4 people sitting in this room heard breast cancer.
Ma'am, but he was constantly.
We also heard breast cancer.
I immediately prompted.
You should have given one answer, not 2 answers at a time.
Sir, we are already saying Bell's palsy. Final answer.
See, our time was not over. Before the time was over, both our other members had said Bell's palsy.
But why you said breast cancer?
But ma'am,
breast cancer.
But ma'am, we have
before the time was over, ma'am, we could.
Before the time ends, we have confirmed our answer as Bell's palsy.
Who confirmed? She gave the answer breast cancer.
Sorry.
Actually, once you submit the answer, the submitted answer is being taken. The first answer which is submitted is being taken as the correct answer.
And there is no such, ma'am, please, I beg your pardon, but there is no such clue as submitting the answer while the time remained, or one of our contestants said that it is Bell's palsy. Rather, both the contestants said it is Bell's palsy.
Yes,
but you were sitting in, let me ask our organizers, Dr. Ramesh is here and Dr. Vinod is here. and he will tell us what to do in this situation, because I don't think that this needs to be done. Once you have spoken as breast cancer, so I don't think you should be awarded.
Ma'am, I'll tell you one. Ma'am, can I speak?
Ma'am, I immediately pointed
That was our first response.
Our second quiz masters and the organizers are denying this thing, that we should not have
first answer should be the answer.
Ma'am, can
the first person who is
The
speaking in
first
front of
answer
the
should be
screen.
the answer. If you have said the wrong answer, then the question is over.
Ma'am, but
Sir, there
before
is
the
no
time
way.
ends and before the final answer was Bell's palsy only.
Sir, there is no such clue as final submission. That was my initial response.
Before that only,
This up to us.
all the contestants were giving like this only, and ma'am, you asked final, what is the final
Yes,
answer?
ma'am.
And we
Everyone else is being given a
the
chance.
answer within 5 seconds.
They are given chance, but they are not being awarded the marks. They are given chance,
Everyone is
but they are
being
not
awarded.
given.
Ma'am, can
They
I
are not being awarded marks even after the
Can I
time
say
is up.
something? Team E ka time was over for one question for which they were awarded 30 marks. We didn't speak. Everybody was like, Team C is cheating, cheating, cheating. He was going back and he was just speaking the answer, and nobody is considering our response because everybody wants Team E to win. That is the fact. That is what everybody is noticing.
Our answer
We have
for
a
the
tiebreaker
delta
out
wave
for you,
was
don't
not
worry.
Ignore
If you
the
feel
team,
like,
but this
because what
question-
input we have is, we have from the attendees and we have the input from the organizers. It's not that we want Team E to win. If it would have been so, we would not have conducted this quiz. And there is no point in raising the question.
No, ma'am.
On this thing.
But we have prompted the answer before the final, and we have prompted before the half time only.
Yes, ma'am.
It's not like we have given the answer.
And if you wanted to raise the question at that time, you should have said this thing at that time itself. There should be no
Both of us had answered
discussions on this. The time was over.
Both of us had answered simultaneously. I was sitting in front. Maybe I was more audible. He was
Yes, you were audible. And you were very much
not
audible.
but both the other contestants were constantly speaking Bell's palsy. Why is it that only my answer is being considered?
All the organizers are saying.
But ma'am, I think this is being partial to Team E, because there were two incidences. I'll tell you the
Ma'am,
previous
they are
incidents.
questioning the integrity of you as a quiz master. Please take this into note. This is really unfair. We being
But
from the
ma'am,
same
Then we
institution
change
are
this
not-
question for you people.
Ma'am,
We
okay,
change the
you can ask
question for
other
you
team
people.
members also.
We don't
Ask
consider
other-
this question to be
ask other-
answered.
Okay, ma'am, you can ask other team also. Let's do not consider our and Team E opinion.
And ma'am,
just
initially there was no such clue as a final submission. While the time lasts, we can answer our question while there are 10 seconds left.
Ma'am, she is also suffering from breast cancer, so they answered this, and after second question, their answer was right.
Yeah.
Team C, kindly note.
earlier when I was sitting, we discussed, and then she was the leader. She always answered the question.
No. But thing is, this round is running for the second time. There were 10 questions in this round. Let you people listen to the final decision.
But
There
ma'am,
were
actually is also suffering from breast cancer. They answered this, and when you ask the second disease, they answered Bell's palsy. So the Bell's palsy is also correct.
She had risk to develop breast cancer. She never suffered.
देखो भैया, breast cancer उसको था ही नहीं, तो वो पहला जवाब
Saying that she did not have breast cancer. This is right because her aunt has breast cancer. BRCA1 mutation, वो आंसर आपने second बाद में दिया था, उसके लिए Bell's palsy आंसर उन्होंने दे दिया था. तो वो सही है.
So the question is, first clue, then second clue, then third clue, and after the third clue, the question displayed is.
back to back answer कर रहे
थे. Listen, stop everything. Stop the discussion right here. There are 10 questions in this round, and we are probably on the 9th question of this round, right? So we are nullifying last 4 questions of this round. So we will be deciding what you have already told till first 5 questions of this round. So no answered question will be dealt for any of the team after question number 5.
Okay, ma'am.
Sabke number cut. Last 5 questions are over. So no discrepancy. So first 5 questions will be considered for this quiz, and next 5 questions are considered null and void. Now we will be only directly displaying you these scores.
Last 5 questions. Okay.
So we finish this quiz right here, and only first 5 questions will be considered, and last 5 questions are considered null and void for every team. Is that okay? Now please all teams speak up.
Yes, ma'am.
Yes, now we are going ahead for the results. Let's look for the results and then we'll have, we are ending this quiz right now.
BRCA1 BRCA2 आपके जीन्स हो, ये जो जीन के लिए उनकी फैमिली में एंजल में जो फैमिली होता है तो तो जी सर
अब हमारे पास ब्लडी बैटल वाला नहीं।
व्हाट्सएप करते हैं कैसे करते हैं उसमें डाल के अपना सर्टिफिकेट है हाँ उसमें डाल सर के साइन डालने
अमित को व्हाट्सएप करते
अमित को व्हाट्सएप करके उसे डलवा के भेज दे अमन ऊपर ही काम
डॉक्टर अमन को अच्छा वो प्रिंट निकाल के देना सर्टिफिकेट सर हम हार्ड कॉपी दे रहे हैं
एक यहाँ पे फोटो खिंचवाने के लिए मैं वैसे चाहिए सिंपल
मैं अमित को व्हाट्सएप कर
ये हो गया मतलब
हाँ जी
करवा ले काम
मैं करवा
सब निकलेंगे
ठीक
और सर्टिफिकेट वगैरह आज ही मिल जाएगा
नहीं
Ma'am, your mic is muted. You are not audible.
So this will be a tiebreaker round, and there will be only a one question. I have asked all the organizers to log in so that there is no controversy over it. Right? On first clue, before you have to bid, first you have to bid. The highest bidder team will get a chance to answer. The team who gets the answer, who gets the chance to answer, if the team answers correctly, the team scores the bid point, and if the team does not answer correctly, half of the marks will be deducted of the bid.
See or इतने hypothetical situation में जाओ 20-30 हजार बिड नहीं करना
Now tell me who is going to bid. Only two teams are there, team C and team E. Now the chance is yours. Team C and team E, all the team members I would like to see in the screen with their raised hands. Team C and team E.
While answering, you will have to keep your hands raised.
Is that okay? Chalo,
team C and team E, please speak out your
now tell your bid points. How many points would you like to bid? Team C and team E. Now tell me how many points would you like to bid?
See, unmute yourself.
Ma'am, please tell me the game rules.
Ma'am, we missed the game rules. Our internet connection was a bit unstable. We just know that we have to bid. What did you say before that?
I know. Now everything will be stable.
Yes, ma'am.
Now everything will be stable. This is a bid round, right? Only there is one question. The team who bids the highest will get the chance to answer. अगर सही जवाब तो बिड के नंबर जुड़ जाएंगे, वो टीम जीत जाएगी. अगर उसने टीम ने बिड किया और गलत जवाब तो दूसरी टीम जीत जाएगी.
बिड के नंबर माइनस हो जाएंगे, आधे नंबर बिड के, पता नहीं तीसरी टीम जीत जाए। फिर भी मतलब अगर 50 की बिड लगा दे,
Ma'am, it's a tiebreaker. No other team can win. Only two teams can win.
Only two teams can win. Only tiebreaker is for team C and team E.
Team A is out of syllabus now.
Of team C and team E. Now who
And
is
you have
going
to
to
answer
bid?
with the raised hands.
And all the team members will be sitting. I want to see their hands.
हाँ बिड बोलो, बिड तो पहले है ना, क्वेश्चन तो दिखाने के बाद नहीं। हाँ, they both have to keep.
दिया इसको इतना तो भेज दिया।
लगा दो सारे।
टीम लगा रही है, नहीं लगा रही। लगा दो पेन पे क्या।
सी को लिख देते।
मैम लगा दो सारे।
Will bid at 20 points. Ma'am, you're not audible.
Team C bid at 20 points. Team E bid at?
Team E
10.
Same. Then this is not valid.
10 points.
So team C has to answer.
Right जाएगी, left जाएगी।
So team C has to answer, right?
And all the three members have to keep their hands raised while नहीं, team E तो out of syllabus होगी, team E नहीं चाहिए, team C only. Team C has to keep their hand raised, both hands raised, all the three members, and then you will reply for the answer.
Animation देंगे, इसमें है कि नहीं?
बल check कर। Mute है।
एनिमेशन नहीं दिया तो आप सिर्फ क्लू दे दो, एक क्वेश्चन ही तो पूछना है।
हमें चाइल्डहुड पिक नहीं दिखानी इसके अंदर, सिर्फ 2 क्लूज के ऊपर दे हैव टू टेल द आंसर।
पहला क्लू बस,
सिर्फ पहले क्लू पे एक ही क्लू।
हमने एक ही क्वेश्चन पूछने को तो बोला है, एक ही क्लू दो, आप डिसाइड करो।
अभी तो गैमा गैमी होगी सर मॉल की है सर। 5 मिनट और दो सर बस।
और लास्ट क्वेश्चन चल रहा है अभी।
हाँ लास्ट
तो पता था ये प्रॉब्लम आ सकती है।
सुनो तो नहीं सर, चिंता ना करो, ये काम करते हैं।
क्या कर रहे हैं
अब उनकी पसीना आ रहा है।
उन्होंने उनको मौका दे दिया तो उन्होंने बिट कर दिया 20 पे, उन्होंने कहा 10 पे। सही हो गया तो जीत गए, तो खत्म हो गया। तो बात है
उन्होंने उस कम कर दिया ना एक
उनको, ताकि वो फर्स्ट।
पर एक बात है, अगर ये
There will be only one clue. You have to identify the celebrity only on one clue that will be displayed on the screen. There will be only one clue.
Unmute yourself first.
Team C, unmute yourself.
There will be only one clue on which you have to identify the celebrity. And there will be 10 seconds to answer.
Girl को को हाथ ऊपर करें। You have to keep your hand raised while you are answering.
In front of camera. And all the teams I would like them to switch on your timer so that there is no discrepancy regarding the time as well. There will be 10 seconds.
Team E mute.
10 seconds.
ये बार-बार mute क्यों कर दे रहे हैं आपको team C?
Don't mute now. Now I am sharing the question.
Hands.
I want to see your hands.
Keep your hands like this and then answer the question. You have only 10 seconds.
So the question is,
Keep your hands like this.
M बोले तो मास्टर में ब्लास्टर, B बोले तो बिंदास डॉक्टर, B बोले तो बेमिसाल एक्टर, S बोले तो शाना कैरेक्टर. Who is the famous lyricist of this song? Time starts now.
Keep your hands like this. Keep your hands, both hands.
टाइम हो गया
टाइम हो गया 10 सेकंड हो गए.
Time's up.
बस.
-20.
ओए. बताओ तुमको आंसर तो बताओ.
So the answer is Rahat Indori. I hope all your queries are sorted out now. And I would like to still welcome any disputes in this quiz.
Ma'am, you have not answered, so
you,
it's not negative.
नेगेटिव नहीं हुआ ना, नेगेटिव थोड़ी ना हुआ.
बिड हार गया भाई वो. बिड हारने का मतलब है जुआ में हार गए वो 20 नंबर.
सट्टा था वो.
सट्टा था
मैम, मैम अब एक क्वेश्चन टीम दूसरी से भी पूछो, अगर वो भी आंसर नहीं दे पाए तो फिर इक्वल हो जाएगा ना. अगर या तो वो आंसर दे
यार नए रूल बनाना बंद कर यार. कुछ बात
टाई ब्रेकर में एक ही टीम को जवाब मिलता है, चांस मिलता है जवाब देने.
उन्होंने बोला ना आंसर नेगेटिव होता है हाफ नंबर कटेंगे. ये नहीं बोला कि आंसर नहीं दोगे तो नंबर 0 हो जाएगा. ये किसने बोला था?
So with these controversies, I have tried my best to sort this thing out.
Yes.
And I have tried to give you some insight regarding the medical ethics. And the winner for
Have a nice day.
now let's see the scorecard. The winner is team E, I guess.
एक मिनट गैस नहीं ना वो आनंद भाई क्या
Scorecard I would like to.
बंद है. So first winner is.
So team E is the winner and team C is the runner-up team. And that is also not a bad thing. You should not fight like this.
Ma'am, it is not bad, but we are not being bad losers, and it is not a big deal that we win or not. But
Fighting like anything.
Must have noticed that there were 2 incidences when they were
fighting like anything. I don't want any fights
yes,
on
ma'am,
the
it was not a
ending
fight,
day of
but
this.
there were 2 incidences when there was partiality with team E. And we were
देखो
not
जो
to
अगर
say them.
ये तो जो जीतता है उसके लिए तो कहा ही जाता है आपके लिए पार्शियल आपके अगेंस्ट पार्शियलिटी.
कोई जीतने वाली बात नहीं है. पार्शियल सभी को दिख रही है.
मैम
There is something called as losing with grace.
Appearing to everyone, every other team. Special effort was being made to make team even in 2 incidences.
There is something called as winning and losing with grace.
And probably you are losing with grace. Probably you are not losing with grace. And if you are questioning the quiz masters, and then I don't have anything to say to you people.
Ma'am, just a minute, ma'am.
I think we've been. I think it was an international quiz, and we've been taught from the basics to not question the integrity of the institution and school. Whatever the case
If you still have doubts on integrity, then I don't have anything to say.
I'm saying that we have been taught to believe in that. That is what we should believe in. That basic.
There is no point when I have asked, this is a bid round. The team which has bid the highest marks, and I have given the team, all the teams, to give the chance. Right? I have given the chance to all of you people.
But we are not arguing, but if we won't have bid in this round, for sure team E would have bid and they would have answered.
No, you should have decided that how much you want to bid for this. You should have played smart.
No,
that is the played. They have played smart, that I know.
Even if we would have bid at 5, we would have lost. It was not about how much we would have bid because we were at same score. But anyway.
Team C, it's about the confidence. If you were confident enough to answer, you could have bid accordingly. Team E was smart enough to not bid enough. You were given a fair.
Ma'am, we did not bid because
second
team will give the low bid.
Common sense.
Absolutely. Bidding round.
See, just to make things clear, the first decision also we didn't have any issues with that, and second also we don't have any issues with that. Bid आपने पहले किया था. The whole 5 slots were taken off because you had a problem with the decision. It is rightfully that you bid first.
Free की जीत मुबारक.
It's totally fair, madam. Please proceed, ma'am.
Thank you, ma'am.
Thank you. Thank you all.
Thank you, sir.
बस करो।
थैंक्स लॉट
चीटिंग अच्छी है
चीटिंग अच्छी है